Good afternoon, or good morning to those of you who are tuning in from the West Coast. Thank you for joining us today at Gut Feelings, Navigating Post-Secondary with Crohn's and Colitis. My name is Iman Abdullah, co-chair of the Arts and Science Undergraduate Society Crohn's and Colitis Committee at Queen's University. And I'll be one of today's moderators, along with my fellow co-chair, Isabel Sawicki. We're incredibly excited to be here and pleased to partner with Crohn's and Colitis Canada to bring you today's event.
We just like to begin with a quick land acknowledgement. The Arts and Science Undergraduate Society is located in Kingston, Ontario, and acknowledges that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. As an institution, ASUS has benefited from colonization and its destructive nature. Our complicity has allowed us, both individuals and an organization, to have and provide the opportunities that have made up our traditions for our now 130 years of existence. We are committed to learning more in a goal of allyship and standing in solidarity with Indigenous persons and dismantling systemic racial and ethnic discrimination and other forms of oppression, in and beyond our roles at Queen's, to work towards a truly inclusive campus.
Before we introduce today's first speaker, we'd like to start by sharing Crohn's and Colitis Canada's promise, which is to improve the lives of children and adults with Crohn's disease and ulcerative colitis, and to eventually find the cures. Whether it be public-facing sessions, such as a webinar, or an internal company presentation, Crohn's and Colitis Canada normally includes this promise slide as a beacon for everything that they do.
The Arts and Science Undergraduate Society Crohn's and Colitis Committee raises funds and awareness of IBD at Queen's University. We're able to bring you today's event free of charge, but if you'd like to donate to Crohn's and Colitis Canada, you can text CURE to 20222.
Without volunteers and successful fundraising activities, Crohn's and Colitis Canada would not be able to deliver on their programs. The largest signature fundraising event is just around the corner on June 5th, where people from across Canada will be joining together as one to raise awareness and funds to support the IBD community and to find the cures. If you haven't yet or are new to the Gutsy Walk, I encourage you to go to gutsywalk.ca and learn more and register.
And one final notification is that this year 15 scholarships of $5,000 each will be awarded to post-secondary students with Crohn's or colitis, and the applications are now open. And with that, it is our pleasure to now introduce our first guest speaker, Dr. Moses Fung. Dr. Fung is a fourth-year gastroenterology resident at the Ottawa Hospital. So please give a warm welcome to Dr. Fung.
Alrighty, thank you so much for the warm introduction, guys, and good morning or good afternoon to everyone who's watching this webinar. It's absolutely a pleasure for me to be here to speak to you, just to kind of give you a brief overview of what IBD is, and to just highlight the importance of this issue. I know many of you attending this webinar likely may have IBD or know somebody who has IBD, so it's important that we have a firm grasp of what this issue is, and we'll segue into more talks throughout this afternoon to keep you informed, especially in terms of the nutrition and also the mental health aspects associated with this disease. I think I will share my screen so we can get the slides here. Okay, perfect. So just it'll just be a quick talk this morning from my end. We'll run through a quick anatomy of what the GI tract is, where we find inflammatory bowel disease, what exactly inflammatory bowel disease is, and we'll talk about the prevalence and the causes of IBD, and then highlight just quickly what kind of complications patients do experience and what the treatment options currently are at this point. So as most of you will know, this is the gastrointestinal tract. I find it super interesting, and this is what my specialty in medicine has become. Certainly, this is a whole tract starting from the gum to the bum. Everything that you eat, everything that you put in goes into your mouth, goes down your esophagus. And this is where all the food gets processed, it gets mixed, it gets digested in your stomach. And then it goes down into your small intestine, where your pancreas adds pancreatic enzymes, you get bile salts added from your gallbladder and your liver, and it helps to digest all your food, and this turns it into nutrition for you to fuel your body, to fuel your life, to give you energy. It's a very important organ, especially from my perspective. I'm biased because of that, but I think it's one of the most underrated organ systems in the body because it influences so much of who we are as humans, and how we live our day-to-day lives. And as the food gets kind of processed through your small intestine, the nutrients gets absorbed, water gets absorbed, and toxins that your body doesn't want, or waste products that they don't want to get rid of, or that they want to get rid of, get excreted out into the large bowel, the large intestine, and then eventually any kind of waste products comes out as stool. So unfortunately, with inflammatory bowel disease, this is where some things go wrong. And inflammatory bowel disease, the term inflammatory, it's really an umbrella term between Crohn's disease and ulcerative colitis. And what we mean by inflammation or inflammatory disease is essentially, if you think of it, if you fall and you cut your hand, that area that's injured or there's an insult there, the body tries to repair itself. So when it tries to repair itself, that area becomes warm. That area, all the cytokines and immune modulators go to that area. You get some swelling in that area, and the body tries to heal that spot, and the body is doing everything it can to restore that area back to its normal state of being. So unfortunately, in inflammatory bowel disease, something goes wrong somewhere in the bowels, and this is your body reacting to try to heal that and try to fix what's going on. Crohn's disease is one of these inflammatory bowel disease, and this can happen anywhere in the GI tract. So this can be in the small intestine, the large intestine. Some people do have it in the upper GI system, into the stomach and the esophagus, but that is more rare. We call this disease anywhere from the gum to the bum because it can happen in many different spots throughout the GI tract. And this is known to be a transmural disease, meaning it affects all layers of the bowel wall. This is quite a significant and serious disease, and we do see a lot of other complications that can manifest from this, even outside the GI tract. The other disease under this term of inflammatory bowel disease is ulcerative colitis. This disease is more localized in the large intestine, usually involves the rectum and the anus. Usually a lot of patients have a lot of abdominal pain, a lot of bloody diarrhea. And this is more of a mucosal disease where only the bowel surface is affected. So here's a little bit more of a highlight in terms of where the disease can be found. Like I said, with Crohn's disease, we call it a patchy disease. You can have patchy inflammation all throughout the small bowel and the large bowel. And we can develop strictures and fistulas, unfortunately, from the ongoing inflammation. And ulcerative colitis is more of a continuous disease, usually starts in the rectum. Most people do find symptoms starting at the rectum, and this can progress throughout the large bowel, and then all the way throughout. Just very significant ulcerative colitis, maybe a pancolonic inflammation, which means the whole large colon is affected. So who in Canada has IBD? Unfortunately, this is a disease that's on the rise in Canada. The Crohn's and Colitis Foundation had published an impact report in 2018. And right now, the estimate number of Canadians who are affected by inflammatory bowel disease is as high as 300,000. Unfortunately, this is a number expected to rise to up to 400,000 by 2030. So that's 1 in 100 Canadians. Quite a prevalent disease, and something that we all should have better education about and know how to manage, and know what to expect kind of moving forward. So what causes IBD? And I think this is a question that a lot of patients, a lot of family members, and a lot of people who have interest in this area are looking at. And unfortunately, the short answer is we don't really know. Historically, this was thought to be more of a genetic linked disease. They're thought to be some kind of autoimmune response, meaning the body is attacking itself as the cause of inflammatory bowel disease. There are specific genes, NOD2, that are linked to inflammatory bowel disease and other autoimmune disease, such as rheumatoid arthritis or lupus and ankylosing spondylitis. But as we develop more research and we're kind of getting more into the area, we are finding that there are other factors that are infecting inflammatory bowel disease and other causes that seem to be triggering it. Historically, we used to think that inflammatory bowel disease was a Western European disease. We used to see it only in the Caucasian populations in Europe. But now that we have other countries that are becoming newly industrialized, we see the rates of inflammatory bowel disease rising sharply there as well. There is also a thought now that people with ethnic origins who are typically not associated to have a high incidence of inflammatory bowel disease, when they immigrate to a westernized nation somewhere like Canada or US, and they start adapting similar lifestyle habits, start having similar diets as Western Europeans or North Americans, their rate of inflammatory bowel disease is rising as well, and quite similar to what we had seen in the previous Western European populations. So certainly there's a role within the genetics and the autoimmune aspect that we have seen in the past, but now that's changing as well. And there's more factors that we don't really know a whole lot about, but the research is pointing to new avenues and new areas that are uncovering what might cause IBD. In terms of more environmental factors, we know that smoking obviously is not good for your lungs in terms of developing lung cancer, but we do see a strong effect with smoking and inflammatory bowel disease. We also know that females who smoke and are also on oral contraceptive medications also have an increased risk of inflammatory bowel disease. And there's even some studies looking at air pollution that also has a role in patients developing inflammatory bowel disease. We don't know for sure, but we don't know that a lot of these aspects are kind of in the mix, and these factors are affecting the development of inflammatory bowel disease. And the last area that I do want to touch upon, and I think it's very interesting, and I know you'll have further information later this afternoon about, is really about the gut microbiota. And there's a link with nutrition in that aspect. We do know that patients with inflammatory bowel disease have an altered gut microbiota. That meaning everyone has bacteria in their guts, and that helps. There's good bacteria and bad bacteria. The good bacteria help to digest certain food groups and give you nutrients, but sometimes bad bacteria can lead to infection and lead to an altered immune system. So we know that inflammatory bowel disease patients, they have an altered gut microbiota or altered bacteria in their gut. It's not really clear right now if it's a chicken or an egg effect, whether the gut bacteria was altered, which precludes or which leads the patients to developing IBD, or whether or not it's because of the IBD that the gut bacteria is altered. And, you know, I think most of us are used to the phrase, you are what you eat. And certainly what we eat can affect what bacteria grows in our gut. So very interesting aspects right now in terms of, and in terms of moving forward, in terms of what we put into our systems and how that may affect our gut microbiome, and to see if there is an effect in IBD and if there's something that we can change about that. We don't have the strongest evidence right now, but it's something that is certainly building, and that's something to look forward to in the coming years. So who in Canada gets IBD? Unfortunately, everyone is at risk of getting IBD. We do see two kind of peaks in terms of populations. Most people, the first peak is kind of in the 15 to 35-year-old populations, a younger cohort of patients who do develop IBD. But we do see a smaller peak in the 50s to 70 years old where people are developing IBD later in life. There isn't a significant difference between males or females. And like I mentioned earlier, there seems to be a genetic link there that about 20% of patients with IBD have a blood relative who have IBD as well. Family members with Crohn's disease have about a 4 times risk of developing ulcerative colitis. And on the flip side, if you have a family member with ulcerative colitis, there's about a 2 times risk of developing Crohn's disease as well. And like I mentioned earlier, ethnicity, it can infect anyone. Previously, we thought this was a Western European disease, but now it's no longer the case. And we do see a higher risk in the Ashkenazi Jew population as well. So what can happen with IBD? So from my perspective as a physician dealing with IBD patients, we want to decrease the inflammation as much as possible. Because when we decrease the inflammation, we can prevent the body from trying to fight against itself and try to heal itself and put itself on overdrive to prevent complications from happening. Complications are development of fistulas, which are kind of linkages or passages between the bowel in different areas, abscesses, which is pockets of pus or pockets of infection. If you have long-standing inflammation, unfortunately, this can lead to forming of fibrostenotic tissue, which is like scar tissue in your bowel. If you have too much inflammation leading to this scar tissue forming in your bowel, this can lead to obstruction, which is where the stool contents or the bowel contents get blocked, and they can lead to a lot of pain. And sometimes lead to perforation of the bowels. This is a major issue for patients with very severe inflammatory bowel disease, and they may require surgery because of that. And when the gut is not functioning very well, this can lead to a lot of malnutrition. So these are important complications to watch for, and that's why treatment or getting down to the root cause to decrease the inflammation is very important from our perspective when managing IBD. And lastly, like I mentioned earlier, patients with Crohn's, they can develop extraintestinal manifestations, which unfortunately link to the whole body effect of this kind of inflammatory disease. People may develop joint disease, they may develop various skin conditions as well. And then lastly, just a very quick overview about IBD treatment. From my perspective, we try to decrease the inflammation. We do it with a number of medical means, and it depends on where the disease is located and how severe the disease is located. So you may hear different medications being used, things like steroids to bring down the inflammation as quickly as possible, and then different agents to maintain that level of suppressed immune response. So things like 5-ASA or immunomodulators like methotrexate or Imuran. And now we've also developed a lot of new biologics, it's a very exciting avenue in terms of new research is coming out and new medications are starting to be available. Within the last 2 or 3 years, there's been a big increase, which I think is very exciting for patients, especially if they are starting to fail the first or second line treatments. So things like anti-TNF agents, anti-integrin agents, JAK1 and 2 inhibitors. These are all starting to be in the mix, and there's a lot of new research, especially in the last year, that's coming out. So there is hope in the future for new medical management for these patients. Sometimes people do have really significant disease and they do fail on medical management, and there are surgical management options as well. But really kind of an overview of what we want to do in terms of the treatment. We want to decrease the inflammation. We want to prevent complications from occurring. And ultimately, we want to improve the quality of life for our patients managing Crohn's disease or ulcerative colitis. This is a lifelong disease, and if we can decrease the inflammation, many of our patients do very, very well. But obviously, there are many complications, psychological, social, and medical complications that occur. So as long as we can decrease the inflammation as well as possible and improve your quality of life, that is our main goal. So really just to kind of open up this afternoon, where are we now? I think we are closer to identifying causes and triggers. I think there's a lot more that we don't know at this point, but I think this field is very exciting and growing rapidly. In terms of treatment, we do have more medications that are starting to come. We have good evidence that's come out in the last 1 to 2 years. So there are new agents, there are more medications that are coming. So this is a very promising field. Unfortunately, this is a disease that seems to be quite prevalent and growing within Canada. But I think for our patients and people who have it, and people on this webinar who may have it, there is a promising future. And I think it's exciting that we get to talk about this today. So with that, I hope that's a quick overview of IBD, kind of what it is, how we manage it, and where we are now. And I'm happy if I haven't gone over time, if there's any questions that anybody wants to ask.
Yep, so we have some time. As she was put in the chat, there is a Q&A feature for anyone to ask any questions related to Dr. Fung's presentation, and we can open that floor up now. We have probably around 5 minutes or so. So yes, if you have any questions related to that IBD overview, please let us know. So one question came in for Dr. Fung. Is there a good time to go to the ER or call your GI when you are experiencing a flare-up or a flare?
Yeah, I think this is a really difficult question to answer. It would be really dependent on what kind of symptoms you're having. Obviously, anytime that you are feeling unwell or feeling uncomfortable, you should reach out to your gastroenterologist. If this is something that you feel like is off your baseline or your symptoms have worsened, definitely seek medical attention. It's really hard for me to advise based on this question. But definitely if your symptoms are worsened, you should speak to your GI doctor. If you have anything that's worrisome, worsening pain or fevers, then you should seek faster medical attention from your emergency department.
Okay, perfect. And then, yeah, there was another one that came in as well. Does a 5-ASA medication make a teen immunocompromised?
Okay. So to a degree, the 5-ASA is one of our less potent medications. I think to a degree there is a bit of immune suppression. I think it's certainly anytime we start patients on medications like 5-ASA, we do say that there is a risk of being immunocompromised. Certainly there is more risk for infection or certainly developing risk for infection. It is one of our medications that we would consider being immunocompromised. It's not as significant as other agents, but definitely something to watch for. Yes.
Perfect, thank you. And then another question here. What are you most excited about in regard to new treatments?
New treatments, yeah. I think there's a lot coming in that are very exciting. I think the biologic agents, previously what has happened is a lot of patients have to come in regularly for infusions. And that means they have to take time out of their lives every 4 to 8 weeks. They have to come and get an IV infusion. And when these 1 or 2 medications fail, unfortunately, they have to go for surgery. What I'm excited about is we're starting to get new agents that are oral agents. And these are medications that you can just take at home. You can take a pill once or twice a day. You don't have to take time out of your week to come into an infusion clinic. And these are medications that we're starting to use as our 3rd and 4th line agents. So if you failed the 1st or 2nd line agent, we have new options as 3rd or 4th agents that people do very well on, and they can avoid surgery. So to answer Dr. Tripp's question from that standpoint, being able to have an oral medication and being able to avoid surgery, yeah.
Mm-hmm. Mm-hmm. And then yes, so yes, just in regards to that last question, we're just asking about what is the current first-line treatment for both UC and Crohn's.
So there are a lot of different, I would say, first-line treatments. It really depends on the severity of the disease and the patient's health. There are different agents that we use depending on where the disease is located and severity of the agents. I think it would really depend. I don't have a one medication that is a be-all, end-all.
Right. Okay, and I think this will be our last question for you, Dr. Fung. But is there a potential for those who are currently on IV medications to switch to oral medications?
Yes, that's potentially something that may happen. And definitely if you are a patient who is currently on an IV medication, who may want to switch to an oral medication, that is something that when these newer agents start coming into market, to speak to your gastroenterologist about that, potentially you may be someone who is a good candidate for the newer medication.
Perfect, for sure. Okay, I think we'll wrap up that Q&A session with Dr. Fung now, just so we can keep on time for the rest of our conference here. With that, we would really like to thank you, Dr. Fung, for joining us today and getting us started with that overview of Crohn's and colitis. It was a really excellent presentation, so we really appreciate that.
Thank you for having me.
Yes, have a nice day.
Thank you again so much, Dr. Fung. And now we're going to be switching gears a little bit into our next presenter. It's our pleasure to introduce our next speaker, Dr. Dean Tripp. Dr. Tripp is a Crohn's and Colitis Canada funded researcher, professor in the Department of Psychology here at Queen's University, and cross-appointed to Anesthesiology and Urology at Queen's. He completed his PhD in clinical psychology at Dalhousie University, holding several university positions before joining Queen's in 2001. He has published over 100 peer-reviewed publications and chapters, 5 treatment manuals, has developed 14 annual pain education events in Kingston, has presented his research in many national and international forums, including TEDx, and has consulted around the world on clinical research and patient engagement. Dr. Tripp has nationally and locally been awarded for his excellence in teaching and research. His research has focused on pain and psychosocial factors associated with adjustment with various patient populations. Dr. Tripp is also the current lead for Imagine Spora Mental Health, Psychiatry and Psychology Working Group, one of the largest GI research groups in Canada. We would now like to welcome Dr. Tripp.
Thank you very much. I'm going to share my screen and pop this presentation up. I believe you can all see that now. Okay, very good. I just want to make sure before I go forward. Thank you for that warm welcome, and thank you, Imam and Isabel and Dr. Fung, for setting the stage and doing it so well. I'm very happy to be back and talking about IBD mental health research, and in particular talking about why it's essential, why it needs to happen, and what we're finding out currently, and what we need to do about it. I want to talk first about this concept of who for what in the research I'm going to present today. I'm going to give you a highlight of that, but I want you to remember that when we do the research I'm going to present to you today, we're talking about real people filling out, giving us real information about their lives. In the studies I'm going to review today, not every patient is in the worst place scenario in that research. Some are in the worst place scenario, and some are in the middle. And it's really important to understand that, what we're concerned about is that kind of teeter-totter, or that tipping perspective between reasonable mental health, stress, vulnerability, to kind of the teeter-totter tip. And obviously, we're very concerned about our patients who are having a hard time. So I want to start with that so you understand that the research I'm going to share with you today is about that perspective in whole. It's not just about any one sort of part of that umbrella that our patients are experiencing in time. So with that, I'll open up with just this first slide that gives you a little bit of information about where we're going today. I want to try to make a pitch for psychogastroenterology and just talk a little bit about what I think that is and how it works today and where I think we're going in Canada and in the US in particular. I want to talk about studies then, IBD pain mapping study, our quality of life study, our recent group therapy study, and I'm going to talk about two sort of studies that look at sort of suicide risk in our patient populations to give some perspectives on that as I wrap up. So all of these studies are current, they're very new, have a variety of other studies that we've done from our research lab here at Queen's, with my excellent students like Catherine Fretz, for example, and Julia Morrow, and Valentina Mihalovic, just to name a few. But I'm going to talk about our most current research, and some of this research is yet to be published. It's that fresh. So I want to get you right up to where we are in some of the real exciting things that we've talked about recently in our science. So let's talk a little bit about psychogastroenterology and what that is. This picture really kind of paints it up for me, and I think I want to introduce you to this framework. And the emphasis again is on how you get service in a GI situation. And I'm a health psychologist background, and that's where I come from. So for me, having worked in pain and abdominal pelvic pain conditions for the last 20 years, it's been a really interesting shift to really hone in our focus as a group on the GI conditions and IBD in particular. This graphic here shows a couple of things I think that are interesting, and I believe you can see my cursor on the screen. But we want to think about the general population of people out there, working through their IBD and trying to kind of manage it and what they might need. So there are different sorts of ways to think about, the psychology and the psychological assistance in GI disorders. So we can think about, this sort of general psychologist. And, if you're experiencing mild to maybe moderate symptoms, quality of life impairment a bit, and a couple of other things like that, like, high functional status, you're still kind of able to kind of work and so on, but your disease is kind of, takes it out of you every now and then. Maybe seeing a general psychologist is really where you fit, in terms of that. So getting therapy, seeing a therapist, sort of a social worker could even be useful at these sort of stages, or just really also branching out, talking to friends and getting support from support groups that are arranged across Canada in different places like we have here at Queen's. And I think that type of communication can be helpful and useful and has a place in the psychology of IBD. I think as well, there are, a group of people that will benefit from comprehensive psychiatric services. And that can be, for suicidal ideation, severe anxiety or eating disorders, substance abuse, or even things like opiate dependence. And you can see here that both of these loop into psychogastroenterology, because I think, psychologists also work in that kind of structure. They work throughout it. So when we think about the psychogastroenterology, we're thinking really about someone who has more severe bowel symptoms. Quality of life is definitely impacted by the symptoms. You have some insight, some motivation to kind of want to work through your stuff, but still it can be very complicated and upsetting. So there's kind of like a couple of different areas here. And I have these arrows joining some of these pockets together because I think it's time to combine really the discussion about psychological health and not have it under a pillar of psychiatry, social work, but really to have a multi-dimensional approach as we should take in managing a very complex disease. So these integrative teams are really what I'm all about today. I want to talk next with that background a little bit about some of our science. And this first study that we completed, just published very recently, hot off the press, is still actually in press, as they say, is a study that I wanted to look at pain. And Dr. Bayak and myself, Michael is a GI doc here in Kingston. We were actually having a beer and talking about life and talking about our patients and thinking about stuff. And he goes, you know what? I have a lot of patients telling me about these sorts of things. And then I took that concern from Michael to a patient group And we started talking about this in the community about, what pain is like and how it affects you and so on and so forth. And we came up with this study because one had not been done like this. It seemed simple enough. Someone should have done it. But we wanted to know about IBD body pain, because what is the association of these pain patterns that patients were showing up to clinic with? And how does it connect to outcomes for you in terms of psychological sequelae? So the objectives were basically to kind of body map out pain areas, get patients to fill out information on a body map, and you'll see a picture of that very soon, and examine how these patterns might be associated with things like depression, catastrophizing, pain severity, and quality of life. And I'll emphasize catastrophizing. Just think of it as like being really anxious and really kind of primed to get nervous when you start thinking about your pain. And that is a common experience for anyone with painful or chronic conditions. It's a common sort of thought pattern or a worry. But it's particularly interesting when you think about diseases like IBD that can have a real sense of helplessness in them, or a real sense of uncertainty. And that's really what can drive some of that catastrophic thinking around outcomes and what's going to happen, and it's going to be horrible, and I'm never going to be able to manage it. So we'll talk about these in a couple of seconds, but I want to highlight that because it's a particular finding throughout these studies. This was just a survey collected from patients in our clinic. You can see here almost 300. And the procedure was basically to give a survey to anyone who came into clinic who wanted to be engaged. So we didn't hunt for anybody. We didn't, really exclude anybody. Anyone, who was at clinic, could speak English and was 18 and over, could engage in the study. So from that thinking and talking to Michael and talking to patients, we came up with this idea, and we have these results. So this is what I meant by body mapping. And on these maps, what we had is now patients wouldn't see these maps like this. This is the data of how the patients responded to these maps. But if you can imagine like the IBD only map on that side, and you can see without, if you didn't have any lines or color on it, you just have a map of the body. And what we'd be asking you to do at that stage is just, put an X down and let us know, mark an indicator where you have pain in your body and how bad that pain is. So you can see here what we found is really cool. Patients reported a couple different things. About a third of the patient group reported having what we call IBD pain only. Now, some patients who did not report any pain at all, that's true, but that was in the very minority of patients who came to clinic that day. But for about a third of the group that reported any type of pain, we had what we call an IBD only, pain only group. And you can see here, it's around the abdominal area, around the pelvic area, pubic area, and around to the buttocks and low back. And we called that the IBD pain only group, because that's kind of like the area which we would expect to find pain. And then we had a group kind of in the middle, which again was about a third of that sample, showing that pain had been distributed outside of that. So we saw, head pain up in area 1 under column 2 here under IBD pain plus 1 or 2 other areas. And you could see neck pain, shoulder pain on the back, and then we even see some foot pain indicated by that sample. And then we had another category, which would be obviously much more extreme pain category in terms of area covered on the body. And you can see most of the body is in some form of pain, with still that primary area is being indicated as painful. So this was a really interesting kind of way to look at this, because this is what we heard from patients. This is what we observed clinically, and this had not been published before. So we really wanted to put this out there so clinicians and patients alike would be understanding that IBD comes in a variety of different ways. Now, obviously, this was a one-time sampling, so we don't have this longitudinally, but many patients say that they might end up cycling through some of these depending on where they are in their disease and flare history. And that makes sense if you consider what can happen when disease gets aggressive. So that's the body map, and I think it's important to show that, and I think a picture does a good work on that, understanding how that can be presented in clinic. What we have over here on the other side of this screen really is kind of like the means that we see across the groups, group 1, group 2, and group 3. And this is kind of like the values of the different scores. So here would be pain as a pain severity index, and we see a 5 to a 14 to a 15. So we knew that group 1 is reporting significantly less pain than these other two groups. These are about equal. Catastrophizing is fairly low or relatively low in group 1, but you can see it rises as you go through the groups. So basically moving across to having more overall bodily pain or more widespread pain, the catastrophizing scores go up just like the pain scores do. And then accordingly, we see the scores on depression do a similar type of thing, from a normal rating to a mild to moderate rating to a mild to moderate high rating. So we can see that depression becomes more of a concern as widespread body pain occurs. And we can also see a decrease in quality of life as the pain goes up, of course. And that should make sense from any of you who have experienced inflammatory bowel disease. So study 1 that I'm talking about, I'll call it study 1 today, really has laid down a foundation, a new foundation for pain patterning during clinic visits. And really I really think what we should be doing here is identifying the differences between the type of pain and associated pains that we're coming in with into clinic. And I'll just one more quick comment about this. I thought I had a bullet on this, but I do not. And part of it is, you know, we have some other data, and we've looked at some other data with Dr. Nickel in urology, where we've looked at the comorbidity between IBD and other abdominal pelvic diseases like interstitial cystitis, bladder pain syndrome, for example. And we're finding comorbidity prevalence rates of about 40%, 38 to 40% between IBD and diseases like interstitial cystitis, bladder pain syndrome. So this is really interesting when we think about the body from an overall perspective and overall pain. What are some of these pains and comorbidities? That's really what I think we need to pull out next and really come at an understanding from, because it might be able to be helpful for patients to be able to go, okay, that makes sense. You know, that's the experience of many other patients who are similar to me. So we're hoping that that will happen in the near future. But we don't have that information right now. The next thing I said I would talk about here is your quality of life. And we just mentioned about quality of life decreasing. And this is a very, very new study that we've taken under CCC funding. So thank you for that, Crohn's and Colitis Canada. And this project here, just like the last one, which was funded by Crohn's and Colitis Canada, is a very important study because it looks at the impact on patient quality of life, looking at some of the cardinal, what I would call markers, because pain's very important, obviously. So the question is to study how, what mechanisms, what should we look at? And we really wanted to kind of get a sense of how this could be applied. So we went out and took a longitudinal model examining relationships between pain and health-related quality of life. And we wanted to kind of, I guess, insert that catastrophizing or that anxious thinking and coping choices and see what that could lead to. We were very concerned about that. So this next picture kind of tells the story. And this is what we call a longitudinal serial mediation. So the idea is, if you look at this pain score at time 1, and then other scores that were assessed at time 2, and then finally health-related quality of life was assessed at a third time point down the road. So that's why we call it serial. And interestingly enough, what we see here is there is a significant relationship if you follow the clear lines, not the dotted ones, but the clear lines, and how this rolls, so that pain creates more pain catastrophizing in our patients, which I said, remembers that anxiousness that, oh my God, I don't know if I can deal with this. I feel helpless about this. And I think that might be experienced for many of our patients, which then increases the amount of what we call illness-focused coping. And I'll just suggest that illness-focused coping is like, you know, becoming very sedentary when your pain gets high and your catastrophizing get high. You get a sense of disuse. You get a sense of kind of not being able to get things done. And that's just a piece of what illness-focused coping could look like. And then that illness-focused coping obviously drops your quality of life. So what we see is a mediation between pain and lower quality of life. And these two variables really help us explain why, you know, high pain is related to lower quality of life. Because if you take away these two variables, we know this relationship exists. right? We know that greater pain leads to lower quality of life, but these explain it, or at least give partial explanation to why. So they now become what I would call targets, if you will. And sorry, there's a lot to read on this slide at once, but they're targets. And these sort of what I would call illness stimuli, like a pain, they really do, when you think about them impacting your perceptions of your ability, your feeling, or your amount of anxiousness that you have, or worry, which then can influence how you cope or manage your disease, followed by outcomes in terms of your quality of life. And that's really what this takeaway is from this study. I mean, this next part here really talks about what I just mentioned, so I'm going to go past that. But this model suggests that these mediation pathways are important, and they talk a little bit about mechanism. And in particular, because this is serial and it's over time, it's an important finding because it's a little bit more, how can I say, concrete, because we measured across time and found this effect. So we think that obviously this supports some of the earlier research we just showed you, where catastrophizing in pain, as widespread pain elevates, we see these types of things occurring more often and with more power in our patient groups. So this sort of seems to fit well with that story at this point. So, you know, when we think about pain predicting future quality of life, yes, that happens. We know that, but also how, you know, what are the mechanisms that might be at play here? These are important to know for therapy. They're important to know for self-management. They're important to know if you want to help someone cope. These types of things are discussable, they're manageable, and they can be made better through interaction. So that's a good part of the story. So when we talked about therapy, one of the other things we've done, and this is again a CCC supported grant. This is brand new data I want to share with you again, that we are in the process of kind of writing up and using in other projects that we'll be launching relatively soon. So let's talk a little bit about what we do with our group therapy, because we decided to go out, me and Dr. Gates and our group again from Kingston, Dr. Ropaleski and Dr. Bayak, and we went out and we said, okay, we want to look at adjusting for these things like catastrophizing and anxiety and maybe even mood, and talking about how we can make people feel better. So part of what we wanted to do was use a group therapy instead of an individual therapy for a couple of reasons. One, the orientation is solid, whether you're in group or individual. Cognitive behavioral therapies are very, very good. And I can tell you more about those later if you have a question on what that means. We also provided a treatment manual for this group. So the hope is that we're going to be able to produce this manual, which we're still working on at the moment, but have it produced as almost like a playbook for other people, other therapists in other hospitals or other locations that want to follow this program along if it has benefit for our patients. So this was really the concept of how to test this modality and get it working for our patients in a group setting. I like the group setting because I think part of it is you're not alone. You're talking with other people. And I know it's difficult sometimes to have those discussions, but I've seen it in almost every group. You know, the group is so much a big part of what happens therapeutically, on top of delivering these modules to people and challenging their thinking for self-management. It's just great to see patients come together and form their own little kind of support networks and support groups following an approach like this. So let's talk a little bit about the outcomes or the data. So part of what we found was that catastrophizing over the sessions on the right-hand side here dropped away. So we had a control group, which didn't get any treatment for like 8 weeks, versus a treatment group that did get treatment. They were randomized to each, and the control group did get treatment after they had done their 8 weeks of kind of surveillance. So they helped us, we recorded information on them. So they acted as a control versus the people who were treated. And what we can see here under catastrophizing is that for the control group that had no treatment, they had no change. For the treatment group over 8 weeks, what we saw was a gradual decline in catastrophizing and a very significant decline from like a score of around 24 all the way down to about a 13. So that was a good finding. Very happy about that. And then I'm going right to left here. We wanted to target shame as a variable as well, because a lot of patients were talking to us about the shame that they felt about their disease and how they found it difficult to speak with other people and so on and communicate and advocate for themselves. So we can see similar results: control, no changes; treatment, significantly changed. Let me go back. Sorry, my computer's a little excited. Let's talk about anxiety on the other side. And again, you can see another interaction where we see no change in the control group, but we see a significant change in anxiety scores in the treatment group. So those three significant findings from the therapy are important, and they help us think about adjustments that can be made. I mentioned earlier, catastrophizing is important in pain and pain spread. It's important in predicting poor quality of life. And we see here that it can be modified, that targets like catastrophizing and decatastrophizing therapies, or de-anxiety provoking therapies, or fear reduction or reduction therapies, you can call them whatever you like, but they can be helpful and they can be useful for your patients in clinic. So that's really an important finding. There's other variables that came close to changing, but the N that we had in the study wasn't huge. So I figure with a larger size sample than what we were able to get in this study, we would see changes in mood as well, but we did not see those there. The thing that's really novel to think about is that we looked at pain catastrophizing, but I also want to note this thing called generalized catastrophizing. So just means, are you anxious? Are you ruminating? Do you magnify threat of some of the thinking that you do in your life towards your disease? And do you feel helpless? That seems to be a real strong pull, because some of the patients that were in our psychotherapy group did not have a lot of pain. They were either in remission or they had pain, but it was at what they would consider a manageable level. So that was a very interesting piece of the research as well. So there's a place for this type of anxious, helpless thinking in regards to your disease and what it can do to you. That's important. And I just want to make that point before I go into the last couple of studies. So just, and I said suicide risk perspectives, and I'm going to show you two studies, a 2020 and a 2021 study. So they're relatively new. And the background is obviously in place because the more that we talk to our patients and the more we are concerned, especially when you think about the pandemic and what's happened, we know that stress and distress has elevated for everybody, but it has particularly been elevated for our adolescents with IBD and young men and women with IBD and even older adults with IBD. So we know that this has been a bubble that's been going through. So we were very concerned about these things sort of, pre-pandemic, but also sort of initial stages of pandemic. And that's when this data was kind of collected around that time. So one of the things that we wanted to look at really was the linkage between IBD and suicidal behavior, and particularly because it was limited and the findings were kind of mixed. And also, in our opinion, they were not clearly connected to theory very well. It was more just about, oh, yes, this is happening. We think it's this number versus, well, why? So we really went after the why. So we wanted prevalence estimates for suicidality in our patients. And then we wanted to really look at what predictors and what kind of progression risk model might we be able to come up with from your patient reports that were provided to us. So this picture really, again, is from our 2020 paper that talks a little bit about the progression. If you think about left to right progression, you have IBD symptoms, associated with pain as significantly and strongly, obviously, also associated with shame, and pain and shame really turned out to be predictors of depressive symptoms or increases in depressive symptoms. So pain and IBD symptoms and shame came together, as you can see from our previous research, to predict depression. That's about halfway through this model, because what we did next is say, okay, well, where do we go with this? And if we look at where we go from depressive symptoms, because depressive symptoms doesn't mean suicide risk or suicidality or suicidal ideation. Those terms are used interchangeably at times. But even if we just say, at risk, that means like you have an elevated, it doesn't mean that you're going to go out and commit suicide tomorrow, or you have a plan to do it tomorrow. What it means is that you are at high level of ideation or concern for it. So that's how I want to qualify risk. So from depressive symptoms, we see hopelessness is another key factor. I mentioned helplessness earlier, but hopelessness is a key factor. And two big factors in the suicide literature theoretical perspectives are something called psychache and PB down here. I always want to say peanut butter, but that's not it. So PB is your perceived burdensomeness, or the way you perceive yourself to be a burden on other people in your life. And we know that that's a key feature that's important in predicting who goes from being depressed to having greater suicidal ideation and risk. And we know that psychache above that, which is really interesting, it's kind of like a psychological pain experience where patients who are depressed and severely depressed usually have this concept of just like their thinking hurts. It's like they just want that pain, that psychological throbbing to kind of stop. And it's important to also say that you can be at suicidal risk without being depressed. Like you don't have to be completely depressed to be at some risk of suicidal ideation. So that's an aside, but it's something that's very important to promote. So, but this map, if I can call it this, really is a progression from symptoms to risk that we think is very, very important. And if you look at the numbers up here that we have on the screen as well, reaching approximately 40% of the sample indicating that they were feeling that they were at risk, and about 30% hitting some significantly high numbers, suggesting they were at a similar type of ideation that you might see in a adult psychiatric inpatient clinic. So this study has been significant in the literature. It's been significant in impact in the pan-Canadian panels that we work with, and we're very happy to see that, but we need to do more. So the takeaways from this study, I think, are important. And I just mentioned those 40% of people, supporting this study are at some kind of risk, an elevated risk. That is worrisome, and we need to kind of have more play on that. We need to have, and I'm going to tell you about my wishes at the end of my presentation. Suicidal ideation is important here, and it exceeds, in cases of fibromyalgia, exceeds that. And the ranges between that we see in systemic lupus, again, this is above those. So the targets are really clear. We need to look at the mediation between psychache and perceived burdensomeness. And if our patients are experiencing those, that's something we need to be looking as key features. We want to be worried about that stuff, and we want to be taking our patients in, and we want to be talking about those things so we can make that better, because we can make that better. So the last one I want to talk a little bit about is this recent data that we completed, just 2021 paper looking at childhood trauma and its association to suicide risk in IBD populations. And this, as you can imagine, came out of the last study that we were looking at and thinking just again about, well, what other risk factors are involved that we're not seeing much of in the group. So we did a serial mediation under the objectives here. You can see that for childhood trauma, resiliency, depression, and then ultimately maybe suicidal ideation / risk. So my question is, are resilience and depression significant intervention targets? And should we be going after those as well? So here's a picture that again gives us the words. The blue lines are the lines that are significant. And we can see here that greater childhood trauma, and we have a variety of different ways to assess that, but childhood trauma knocks resiliency down, okay? And then that resiliency, if you go across the top, is, if you had higher resiliency, it would be less depression. The lower resiliency then goes on to affect depression by elevating that. And then you can see coming down from depression to suicide risk, that obviously greater depression is associated with a higher risk of suicidal ideation. We can also see that greater childhood trauma is directly by itself associated here with depressive symptoms and then comes down. So what we see, and we don't see that for resilience, okay, to suicide risk. So what we see here is a mediation where resilience knocks down depression, okay? If resilience is low, it leads to greater depression and then knocks up suicidal ideation or risk. And we also see that this childhood trauma, again, can impact suicide risk through level of depression. So very important findings, brand new. And it just, again, with these two studies, it makes me think, we just have to recognize this. We just have to identify it, and we just have to mitigate these circumstances. You can make a difference in these with therapeutic approaches. We've proven it. Other people have proven it. So we just suggest that treatment and care needs to be thought of as multidisciplinary, multidimensional in some approach, and medical and psychological factors must be included in the same conversation. This from my perspective. So when we're thinking about my wishes, I want to end today by saying, look, the number one thing on my mind, and we've got some new research happening and about to start now, is the psychosocial symptoms and mechanisms of IBD lived experience. They should be widely acknowledged. That's my number one wish. I think it's time, and I think CCC is doing a great job. And I think, ASUS and other places that I've been involved with are doing a great job on getting the word out. But we need to get the word out. And this is why I'm here today. So we need to know these experiences, and we need to acknowledge them for what they are. Also, these psychological symptoms and psychosocial symptoms, really, I should say, and the mechanisms of IBD quality of life and just in general, depression, should be assessed more often. So they need to be talked about, they need to be assessed, they need to be documented, because what that does is put us in a position now we got to do something about it. So more talking, more acknowledgement, more assessment, and then my last wish is that these symptoms and mechanisms that we've provided today for target are targeted and they're treated more often. It's not like they're not treated at all. I just wish them to be treated more often than they are today. So on that, I want to say thank you again for your time. I'm sorry I went through a lot of information. I just have so much to kind of get out there, and we're going to be doing this in a variety of different ways in the future. But I thank you for your attention for my talk.
Thank you so much, Dr. Tripp. That was incredibly interesting to hear. And I think you're absolutely right with being able to acknowledge the lived experiences that so many of our patients have. And that's what we're all here today for. So thank you so much for that.
You're welcome. Thank you.
At this moment, we'd just like to open the floor to any questions that the audience may have for you regarding IBD, mental health, your research. And I see we already have a ton popping up. This is fantastic. So the first question we have is Advil okay for a teen with IBD once in a while, i.e. if having wisdom teeth out?
Well, I'm not going to talk about the medical aspects of Advil in terms of, what it might do to your stomach. I think that's better addressed by a physician. I'm a psychology guy, so I can just tell you Advil in a person without IBD, you want to be mindful of how you use it and when you use it. So I would check with a physician, and again, if you're at a dental office or at any other office, I think again you can be just checking in on that sort of stuff with those folks directly.
Mm-hmm.
Yeah.
Perfect. And in the group therapy for IBD study, do you think that the improvements of anxiety, shame, and catastrophizing are sustained beyond the treatment?
Well, yeah, that's actually, I'm glad that question came up. We were just looking at that, and we have a short-term follow-up that we have, and it was only about 3 weeks post, and we debated whether or not we should include it because there was some argument it's just too close to post. Mm-hmm. So we did see those benefits stay at least out 3 weeks post. So we don't have data because it was a small sample. We don't have data really to look at 6 months post or talking about significant changes out. But I can say anecdotally that one of the things that the group really did for the patients was it was a springboard for them to go out and get individual therapy following it. And part of it was because I think people in general are anxious about going to therapy. I think, it's less so than it was 10 years ago, but there still is this feeling that, something's broken with me and I'm bad. And, this is, again, it's part of that negative thinking cycle where I don't know if I can manage this. I'm just going to be a burden to somebody else. So I think people get caught in those traps. But I can tell you post therapy in one of the groups that we ran, I think like 100% of the people in that group, because we have groups of about 6 people, they all went out and picked up some therapy work after that. So, and they anecdotally again would write me back and say, oh, thank you so much. Like, I've just finished another 6 sessions with my therapist, and I really feel now that I'm in a place where I was able to make this about me, and I'm feeling much better about myself. So that's what I like about group therapies as well. Sometimes it's a springboard to kind of move yourself that extra step, because you have that shared collective of, oh, well, maybe it's not me only, maybe it, so that was really useful. And that wasn't data that we thought about collecting at all. But I can tell you, when we get around to doing something like this again in a larger study, we would definitely recommend, follow up in a variety of different ways because of these changes we see.
Fantastic. And some people are wondering, how do we become part of the IBD group for the psychotherapy?
Well, I mean, it depends on where they would be run. I would look, like if you're in Toronto, for example, and you're an adolescent, I mean, I'd be talking to the people at Sick Kids. I would be talking to, the great psychologist up there, Sarah Kahat, and her group and what they're doing. They have a variety of different things going on. In Kingston, perhaps, we just have well, I can't call him too new, but Dr. Mulder's in town, and he's sort of like a pediatric adolescent GI doc for us now in our community. And his clinic space will be growing. And I know he's keen to set up these types of interventions, for adolescents. And that's another big focus of where our research has gone in the last year or so, when we're really trying to focus in on adolescents and that transition into young adulthood. So I don't have a list of places that would be offering this, but I can tell you in Kingston, we'll be pushing to kind of establish a group like that in the coming year, I would say.
Awesome. Okay. And as well, are there psychotherapists who deal directly with people who have IBD, or is it more of a general based field?
Yeah, and that's a really good question, because as I pointed out at the beginning, a long time ago, and a lot of information ago, when we think about getting help, depending on where you are, you may not need a specialist, right? You may not need a specialist who really is well versed in IBD. You might do quite well with a general therapist. So, depending on your symptomatology, and I find depending on your readiness for therapy, that's another big thing. Like some people are just more extroverted. They're more willing to talk. And I think if that kind of fits who you are, then sometime going to a psychologist would be great, but other therapists that have health experience, other diseases that they've worked in, and sometimes even those without much work in that area can be very useful for people. So I would really say, yes, it's a luxury to have someone who's specialized and, really knows their area. But you may not have that in your community. So the idea then is, well, what fits? Get something that fits. Don't delay getting better or starting to move on your psychology by thinking I need to have that, super Cadillac version of the therapist. Sometimes you come in and I don't know if Toyota's worse than Cadillac, but you know what I mean? Like you might think, oh, that's a lesser version of that thing. But really, I would say just grab onto what you can find. And remember, support groups, people in your community, people like the Crohn's and Colitis support that you can have at Queen's, for example, and other places around Canada, you'll find support there also. So I just think it's at this stage, until we come out with some, ultra version of what, can be useful, go grab on to whatever you can get in your community. I think that's my big ploy. Just do it. Talk to friends, get out from under your feelings and, start to try to get to people that you trust and start with that. And again, it's difficult to answer because I don't know where the resources are, where the person is. But, try to network and find them. CCC will be able to help a little bit in terms of that, maybe what doc and where. Your GI doc will be able to help with that. Your GP might be able to help with it. They know where these people are more than, maybe other folks. So I would suggest network, get your information in there, do your best to ask your questions, and just try to use what's available to you. Don't wait.
Mm-hmm. Fantastic. And we also have a fantastic link that CCC has provided in the chat. Just further support resources. I think, especially speaking from firsthand experience as someone with IBD coming to Queens and just finding out that there were a whole bunch of other students just like me, that already made such a difference because I wasn't used to that. So I think wherever you are, just reach out. It makes a world of difference. And I can speak from personal experience saying that. Another question we have is, would you conclude that group therapy is more effective for IBD patients than individual therapy, or do you recommend them together?
Wow, that's a great question. Good audience today. I think any type of therapy is great. I'm gonna just a hard stop. Anything you can do is great. And it's better than doing nothing. And it's better than going backwards. So, I always say fall forward. So if you're worried about making a decision about one or two, which door do I go? To me, it doesn't matter. Fall forward. So group therapies, I like because I'm an extroverted person. I like the excitement of sharing. I like the excitement of going, what's your perspective? And then, oh, I never thought of that. And then what did you say? Oh, and you go home and you think about it. I love that. For other people who are really nervous, I can tell you that came into our group therapy. Sometimes they might think I want an individual therapy, which is fine. But when they came to the group therapy, they were quiet, but man, did they ever get rocked. They were just like, poof, all this information, all this sharing, all this. And then they start to feel about themselves. They said, I went home and felt terrible that I wasn't doing more. So the next time I came in, I started talking with all the patients. I started engaging. I started to share a little bit. And man, I came home that day, I felt so light, right? So it's the process of therapy that's the most important thing. If you can get that individually, perfect. If you can get it in a group, perfect. So it's not about what's better. It's about you getting to that point where you can help yourself. Mm-hmm. And I think just falling into something that's available is the best thing to do. And don't fall once. Keep falling over and over into it. Like keep coming back to it in different ways, because that process will eventually, if it doesn't, turn out to be super golden experience in the beginning, if you stick with it, you will get benefit. You don't worry about the honeymoon thing. Everything's great for the first session. Oh, honeymoon, I'm so much in love. And then when your marriage goes out to 30 years, well, it's like, oh, no, it doesn't work like that. There's no honeymoon. You don't expect everything to happen in the beginning. You'll get benefit. Just stick with it, because that's a real important point to make.
Yeah, the consistency as well. Like there are going to be ups and downs in the whole process, and it is kind of like a matching process, finding out what works for you and what doesn't work for you. And everyone's experiences are so different and individualized. So just kind of keep trying, keep going at it, and know that there are more resources out there and there are more opportunities to kind of figure out what works best for you.
Well said. You just have to keep digging.
100%. Another question we have are there any contraindications between antidepressant medication and oral medication for IBD? And if a patient chooses this treatment plan?
Well, I mean, I'm going to say that depends. Like it depends on the medications. It depends on what, it depends on what the experience has been of the patient on these medications. So that's really hard to answer. But I would say that, some treatments work best. And in the psychology literature and in the psychiatric literature, some of the treatments that are the most effective for patients have a linkage between medication and the psychotherapy. Mm-hmm. Those are the treatments for some of the, more severe depressions that actually have a better run into the future. So they tend to show most improvement and keep the improvement the longest. Now, some people don't do well on the medications, or they don't tolerate the medications well. So that's a different scenario. So it really would depend on a variety of sort of biological things and medication adherence things and et cetera. But there is some evidence that if you're on an antidepressant, and you're able to kind of manage that through your condition, and you do have a psychotherapy as well, that might be the winning formula, but it's not for everybody. So that's the other thing, it's not for everybody that way, but that could happen. Yes.
Okay. Yeah, I think that's a really good point to make, that it isn't really like a one size fits all, which is what makes it so much more complicated, but
Yeah.
just keeping that in mind. And do you have any thoughts on why there was no change in the mood in the IBD group therapy? Were you surprised by any of the results?
Yeah, actually, I was like, what the heck? This makes no sense. Everyone felt better. There was more engagement. Like, there was more chat. Like if we would have took a camera in the room and recorded how much conversation happened and how much positive versus negative conversation happened, there would have been way more conversation and way more positivity. So just in terms of what happened, left us feeling for sure mood changed, but it really didn't change significantly. Two reasons, and mostly it's methodological and statistical. One, the group coming in didn't have super high mood problems. Their mood wasn't really low. So there wasn't a lot of depression there to begin with. So when you don't have a lot to begin with, they changed, but it was only a small change because they were all feeling not bad in the beginning, right? So that little bit of change, I would have needed 3 times the size of our group to see it as significant statistically. So it's kind of crappy, I don't like that when it happens like that, but it did. The anecdotal reports are like that, but I can't say, oh, mood also got better, because statistically it did not get better. But I think if you look at dropping anxiety, dropping shame, dropping catastrophizing, how do you think they felt? Right? Probably better. But the idea is that the way the data was done on the sample size doesn't allow us to make that scientific statement.
Yeah. Yeah. That's a lot of what I'm figuring out in my classes as well right now. Statistical significance and significance are 2 different things.
That is so true.
This might be a question that we elaborate upon more in our student panel, but it was posed how to kind of balance a flare-up, a social life, mental health. Do you have any advice for that?
Well, I would love to be able to stick around with you folks and talk about that later today and be involved with that. I cannot. I have to go talk to the men's volleyball team who is going off to the nationals. So I'll put on my other hat as the mental training coach, for the boys, and I have to go do that today, or I would stick. But I would suggest, it is really about finding yourself. And I think if there's one thread or theme, I think that's available in this is you're at a really cool age. Like, if you talk about university age, if you were to go from, it's like going into high school, and you're a senior and you look back at a kid who comes into high school and you go, oh my, they're like babies. Like these little high schoolers have come up. When you go to uni and, you go in year 1 and you're running around doing all kinds of silly stuff and, just kind of working real hard, trying to, do your thing, but you just don't have a thing. You don't know what your thing is. And then you're in 4th year and you look at those kids coming in, you're like, oh my, they look like babies. So this is the most interesting transition, because you're going from 18 to like, what, 21, 22, if you're doing grad school older than that. And that is such a very different age. So you're moving from very young adulthood, as I call it, or adolescence, into what I call that emergent adult. Like, you just see the world different, you engage in it differently. And a lot of people develop a sense of themselves through that, a sense of agency, a sense that they can do things for themselves more. Some people with chronic illness have that process bent or stifled somewhat, and it takes longer. So the one thing I can say that's really important in terms of all these potential resources and things you can do is just try. Like, just try to reach out, try to communicate the best you can, find an ally, find a friend, and just start there. And then talk to your family, talk to people who love you, and think about that first. And you're probably hard on yourself. That's the one thing I can tell you, that if Iman was given Isabel, help, how to manage stuff. It would sound fantastic, but would a man do that for herself? Probably not. So, I mean, I think we need to think about fairness for ourselves. So try stuff. And remember that, you know, you would give this really good advice to your best friend, but are you going to give your own advice to yourself as a best friend? It's a really important thing to think about through these years.
Mm-hmm. And I think something that really resonated with me on what you just said as well, speaking from firsthand experience, is the idea that those who have like Crohn's or colitis or going through a chronic illness, you might feel a little bit behind. You might feel like some of those years dealing with all the hardships that we've faced and kind of going through that trial and error process and trying to figure out what we are beyond Crohn's or colitis or hospital life or whatever that may be. That can be very frustrating, and it can be very daunting to kind of go into an experience like university, seeing a whole bunch of people who have this really strong sense of self or feel like they're not behind, and that can be really difficult. So I think things like being able to just talk to people who know you and who love you, and maybe people who do have similar experiences, whether that be inside or outside of therapy, individual group therapy, or whether you have like communities at your school, kind of just looking into that, and just being able to talk about your experiences, acknowledge them, and then try things. Just go out and do things. It might
100%.
feel like you're a little bit behind, but if you just keep on trying, keep on doing, like that's not going to follow you around forever. And I've learned that from firsthand experience.
Yeah, and that is a beautiful way to say that. It really is. And I think, like I say, you know, life is difficult. Life is challenging. It's been amplified by the pandemic. If you look at the way the world is today, it's been amplified in multiple ways, right? And we're very concerned about that. And the one thing that I say, and it's probably be one of the last things I give to you, but I've been so impacted by this. And it's not about being narcissistic. It's about being somewhat focused and caring on oneself. And I remember I was on an airplane once, and this is when the individuals on the airplane that would seat us and all that did a little mock down of like, this is how you do in an emergency. And they would show us how seatbelts work and all this stuff. And they were talking about this thing, and I was standing next to the person that was doing for us, and I was watching them do it. And they said, you know, if there's an emergency and the masks drop out of the sky, out of the containers above you, and oxygen is like what have you, you know, and you're traveling with somebody, you know, like a baby, right? Yeah. And this oxygen mask drop down. Who do you put the oxygen mask on first? The thing you love the most in your life? Or yourself? Why? Why yourself?
Because you can't help the next person if you can't help yourself.
Bingo. So, I mean, that has stuck with me forever. And I think it's one of these things in chronic illness that sometimes people are afraid, like you mentioned. Sometimes you feel under pressure in a variety of ways. So I think it's really essential that people understand that basic thing. And the test is simple. If, like I said, if you're going to give Isabel, you love Isabel, and you're like, I want to help Isabel, and Isabel, you need to do this and this and this and this and this, right? And then it's all of a sudden, you know, you go, why can't you say that and do that to yourself?
Yeah.
So I get it, and I know it's hard to, but it is part of one of the things that you can remember, and not to shame yourself. Oh, I'm bad at that too. Don't even go there. It's part of learning, like you say, to come out from underneath this. So I hope those words are helpful.
They're definitely going to resonate with me, and I feel like some people in the audience as well. It was wonderful to hear. I think we're kind of coming to the end of our questions, but I just wanted to thank you again so much, Dr. Tripp, for joining us today and for your excellent presentation on IBD and mental health. We're incredibly grateful for your time, and enjoy the rest of your day. Thank you so much for joining us.
I will, and thank you so much. It was a great event.
Thank you so much. See you later. Bye.
Bye-bye.
And I'll just hand the mic over to Izzy to introduce our next speakers.
Yes, so next up, we're going to transition more so towards nutrition and diet. So we're going to prepare, we have a joint presentation with Dr. Deanna Gibson and Miss Natasha Haskey. I'll just quickly introduce our next speakers. So Dr. Deanna Gibson is an associate professor in the departments of biochemistry and molecular biology at the University of British Columbia, Okanagan. She did her postdoctoral training at the Children and Women's Hospital in the Department of Pediatrics and Division of Gastroenterology. She is currently working on clinical studies to support dietary recommendations for IBD patients, including the Mediterranean diet study that is funded by Crohn's and Colitis Canada. And Ms. Natasha Haskey is a registered dietitian with expertise in the fields of gastrointestinal nutrition, specifically in the areas of probiotics, prebiotics, and how diet impacts the microbiome. She is a member of the College of Dietitians of British Columbia and the Dietitians of Canada. She's also a co-investigator with Dr. Deanna Gibson on a Crohn's and Colitis Canada funded research program investigating the use of the Mediterranean diet. Natasha is a co-author of the textbook Gut Microbiota, Interactive Effects on Nutrition and Health. And with that, I will pass it on to Dr. Gibson and Ms. Haskey with their presentation.
Thank you so much. Okay, so you guys are going to control my presentation from that end? Great.
Actually, Deanna, I am.
Oh, you are? Cool. Okay.
Yep.
So I'm actually a basic scientist. I'm a microbiologist and immunologist. And so clinical studies are not my forte, but when Natasha came to me to do a PhD, I agreed that embarking on a clinical trial with her clinical expertise in nutrition would be a really good idea. And along the way, she also learned some basic science, and so it was a really good experience, I think, for both of us. So we're going to share some of my lab's research today, as well as Natasha's going to cover at least parts of her PhD thesis. And so that brings us to talking about nutrition and IBD with a focus on fats and particular Mediterranean diet. Next slide, please. So this is the beautiful Okanagan where we are, and it's wine country. You can find my work and Natasha's work linked up to our Facebook page as well as our website. If you can just go through the pictures there, Natasha. There's some pictures of us in the middle pre-COVID. And then on the left-hand side during COVID on our Zoom meetings, and then now just very recently post-COVID or going into the endemic phase of COVID. As I said, I'm a microbiologist, so I have all the members of my group on the far right-hand side forming a micro. That's what we're trying to do there on the grass. And we do participate a lot in Crohn's and colitis events like this one, as well as the Gets IBD, because we are funded and have a very strong interest in gut health. Next slide, please. So as mentioned, we are going to talk about the Mediterranean diet as a potential maintenance diet or beneficial diet for ulcerative colitis patients. And next slide, please. One of the things that we consider, very similar to the Venn diagram that Dr. Fung showed, is the environment, which we can consider food, because food is something that we have to enjoy and take in for survival every single day, multiple times a day. And we can consider the host, so our genetics and all the other factors like the microbiota. So the microbiota is in the gut. It's an enormous environment for microbes to occupy, and they are actually a part of us. We don't survive without them, and so they are a part of the host, but because they can be modulated by the environment like food, we have some element of control over which microorganisms we might or might not have. And so this relationship is something that I like to focus on in my research lab. And one of the most interesting things that I have sort of concluded over my research over the last 10 years is that really diet is something that we can modify. And so the diet-induced disease-associated microbiota, so the microbiota that changes because of the diet that we take in. If we choose the wrong diet, it results in a microbiota that is no longer in a symbiotic relationship with the host. And that's a really important point, because normally our microorganisms live in harmony with us, right? And they provide us a great benefit. Next slide, please. So we learned from Dr. Fung all about IBD, so I don't have to go into that. One of the things that we're going to talk about today is which dietary factors might promote an appropriate dynamic between the microorganisms and the host, and what that means for immunity. And so when I think about gut health, I think about essentially two major things: the microorganisms that are there, the type and what they do, but also what happens to immunity. And we understand that these things are linked, but we don't exactly know what all the microorganisms do quite yet. And so we sort of look at them independently, but I think about them as sort of, influencing each other. Next slide, please. So this is a really beautiful diagram that one of my master's students made, and it essentially summarizes everything that we do in our lab. I like to think about how can we reverse this disease-associated microbiome, because if it's disease-associated, like found in IBD, if we change it to something that is more health-associated, could that influence our immunity in a beneficial way? We need immunity. We need it for things like infectious diseases. But during IBD, inflammation actually causes a lot of damage. And there's some evidence to support that the microorganisms can drive this bad inflammation. And there's some evidence to support that good microorganisms can promote healthy inflammation. Because you need inflammation also to stimulate the healing responses. So even though we're knocking down inflammation when we treat IBD, sometimes that isn't going to lead to, it's never really going to lead to a cure, right? It's just more of a management. And so trying to understand diet as part of those management tools is an important consideration. We know from our research lab and others that diet is one of the strongest predictors of the type of microorganisms that live and occupy in the gut. And this is really important because this can influence disease susceptibility. Next slide, please. So this is a slide that Natasha has actually made. And really what it says is that if we consume what we call a Western diet, this actually leads to alterations in microbes and immunity and the metabolites that those microorganisms secrete. And this can actually support chronic inflammation in the context of IBD. So the questions that we have is, well, what's a healthy diet and how do we get to the reverse situation where we can manage our inflammation in a disease like IBD? Next slide, please. I'm not going to do a poll because this is set up prior, but you can just think to yourself before I get into the next few slides, if you have IBD, should you avoid dietary fat because fat increases inflammation in the body? Well, some of you might be thinking, yes, that's true, because we've been bombarded by a lot of information that tells us that that's true. High fat is bad. This fat is bad. We should eat low-fat diets. You should have low-fat milk. You should have low-fat yogurt. In reality, the answer is false. We should not avoid fat. And that is because not all fats do the same thing, which I'm going to talk about in today's presentation. Next slide, please. In fact, lipids are essential to life, even though they have been demonized for decades. And when I was growing up, we were told we should eat low-fat diets, and even now it's low-fat this, low-fat that. Although now there is some popularity with the keto diet, and so some people might be thinking, well, should I take a high-fat diet? Should I take a low-fat diet? It's all very confusing. In reality, lipids are essential for our development and our survival. And they can modulate inflammation in different ways, depending on the different types of fatty acids that we have in our diet. And this is really important, not only for inflammation, but also for our hormonal balance as well as mental health. Next slide, please. So there's lots of controversial images that you will find when you type into Google, what fat diets, high fat diet, should we eat ketogenic diet? Should we have a low fat diet? Of course, Western diet has always been seen as a bad diet, but what is the Western diet? What does that mean? I think a lot of us think about these French fries and this hamburger, and you probably think to yourself, saturated fat. But in reality, a lot of the fats that are in these fried foods are actually unsaturated fat. Next slide, please. So let's talk about what the differences are between saturated fat and unsaturated fat. I'll come to that in a minute. The first thing I want to point out is that here in North America, we actually have a tendency to eat a lot of unsaturated fats. And the reality is that this is a part of the Canadian Food Guide. So unsaturated fats like omega-6 polyunsaturated fats, they're really rich in the types of oils that you have likely in your kitchen cupboards right now. And that includes vegetable oils like sunflower, safflower, soybean oils. And we do eat a lot. So if you just click on the next forward, Natasha, I just have a little red box there. In fact, since the 1970s, we eat more than 50% of our diet comes from polyunsaturated fatty acids. And we are told that we shouldn't really eat saturated fat. Monounsaturated fat, those found in olive oils, are somewhere in the middle. Next slide, please. So this is similar because I just gave you the USA guidelines. This is actually similar in Canada as well. So in Canada, we're told that we should have 20 to 35% of total energy from our fat calories, and that it's the omega-6 polyunsaturated fat that I was just mentioning make up a good portion of that fat that we should take in. We have no guidelines on monounsaturated fat, saturated fat, and of course, we should include some omega-3 polyunsaturated fats, and those are the ones that are found in fish dominantly. So are those right? Next slide, please. Arguably, I'm gonna say that maybe we're not right in North America, and that will bring us to the Mediterranean diet and what they do. But I just want you to consider really briefly that what we're talking about here is just really subtle differences in the chemistry of fatty acids. And so a saturated fat doesn't have any double bonds. And so that's that example of butyric acid, saturated fatty acid structure. And that's of course found in things like butter. Whereas oleic acid, it's a monounsaturated fat. It just has a single double bond structure, and polyunsaturated bonds has multiple double bonding. So, the oils that we consume have various amounts of these different types of fatty acids, but they actually play a pretty big role on the physiology, inflammation, as well as the type of microorganisms that are in our gut. And so therefore can have an influence on our gut health. Next slide, please. So my lab has spent quite a lot of time over the last decade trying to figure out, does it matter if we take in different types of lipids? Does this have an effect on gastrointestinal inflammation? And I'm not going to go into the details of any of our studies, but you can look any of them up. Sometimes we focus on maternal, sometimes we focus on postnatal, and even in aged. And these are all rodent studies. But the overall conclusion that we've come up with is that it didn't matter if it was a high fat diet, but what mattered instead, so not the calories were important, but instead it mattered the type of fat, whether it drove the inflammatory response or whether it was protective. Next slide, please. And so I'll give you the conclusions that we came up with. What we came up with is that fat isn't always the enemy, And in fact, the detriments of a high-fat diet are very much linked to the types consumed. So corn oil, canola oil, or sunflower accelerates inflammation in the gut in our rodent models of colitis. In fact, if we dive a little deeper into those studies, we understand that it results in an unproductive but damaging immune response. So there's inflammation, but it's not effective inflammation. Next slide. Next point. Olive oil is protective. So that is the monounsaturated fat. It's also the dominant oil consumed in a Mediterranean diet. And again, the top point is the dominant diet that the Canadian Food Guide recommends that we take in. Next point. Milk fat is a tricky one. It's damaging, but it also induces several important protective responses and metabolic responses. And so it's not as bad as many people think. Next point. Fish oil actually works far better when it's blended with saturated fatty acids, but it's actually not good at all if it's mixed with a high level of the omega-6 polyunsaturated fatty acids. Next point. So what this resulted with is going to lead to what Natasha is going to talk about, and that is a blend of olive oil, some milk fat, and fish oil, but low in omega-6 protects against colitis. Next slide, please. And so before we went into the study, we did a scan of what was already known, and we wanted to look for the evidence-based recommendations for IBD patients. And what we found was promising to support our hypothesis. In fact, from the very few studies that were out there, strongly recommended that we should in fact avoid omega-6 polyunsaturated fatty acids, and that there were emerging studies that would support the intake of Mediterranean diet pattern. Next slide, please. And so this is what led to, it all happened at a very serendipitous time where Natasha came to me when I was exactly thinking about this hypothesis. And she was able to take this forward, not only in our rodent studies, but also clinically, which she's going to talk about. But it ended up, looking at this idea that this fat blend would be really important, completely the opposite of what we recommended in Canada, but it'd be really important in supporting remission in patients with ulcerative colitis, as well as reducing spontaneous colitis in our rodent models. And so if we look at the Canadian Food Guide, just here at the bottom, compared to the Mediterranean diet, you can see how different it is when we talk about fats. So in fact, a Mediterranean diet is not low in fat. Recommends about 40%, or it takes in about 40% for energy. Compare that to our 20 to 35% that's recommended in Canada. The Mediterranean diet has about 10% saturated fat, whereas we don't have recommendations for that in the Canadian Food Guide, but if you look through a lot of messages, we're supposed to avoid saturated fat largely. There's no recommendation for MUFA, or monounsaturated fat, in the Canadian Food Guide, but it is very high in the Mediterranean dietary pattern. And so in reality, what we decided to do was a 40% fat diet, which is considered a high fat diet, composed largely of the monounsaturated fatty acids, some saturated fatty acids, omega-3 PUFA, but limited in the dominant fatty acid found in the Canadian diet, omega-6 polyunsaturated fatty acids. And Natasha is the one who carried out both of these studies as part of her PhD in my research group. Next slide, please. So before I hand it over to Natasha, I'm just going to summarize her findings in the rodent model because it sets up the stage for her clinical study. This is a very complicated slide, but it shows how complex studying the gut actually is. And what I can say is that it's the Mediterranean fat blend that resulted in the most protective immune responses, the most protective metabolic responses in the intestine, even compared to olive oil, certainly compared to corn oil and milk fat, which both drove damaging inflammation. And so what we concluded from her rodent study over the past few years is that this Mediterranean-like fat blend is really beneficial in the context of supporting a healthy microbiome, as well as protective immune responses and avoiding damaging immune responses. And with that, she's going to move into the next slide, which is going to cover what we found out in ulcerative colitis patients.
Hey, thank you to the organizers of our session, and certainly thank you to Deanna for kind of setting up the background of what I'm going to talk about. So I'm really excited to share with you some of the results of our human clinical trial where we provided the Mediterranean diet intervention. And it's literally hot off the press in the last couple of weeks. So I'm very excited to share this because it's been part of this PhD journey. So what I want to talk about today is what is really unique about the Mediterranean diet pattern. And the reason why we look at a pattern when we're studying individuals is because obviously we can't just go out and do a clinical trial in patients that have inflammatory bowel disease and just give them solely fat. We would never get that through our ethics board, of course, but also that's not how life works. When we're eating, we eat a variety of foods, and it's those different combinations of foods that actually can have either a potential benefit to inflammation, or it could be detrimental. So what I love about the Mediterranean diet pyramid is that it's actually not a diet. It's actually more of a lifestyle, and it's not a restrictive diet like some of the other diets that are out there. And it allows individuals to eat a variety of foods, but what really is intriguing to me is not only the types of fats that are consumed, but it also includes lots of different types of fiber sources, as well as antioxidants and polyphenols, which certainly our literature is showing some good evidence towards improving the gut health. So I just want to acknowledge that as a registered dietitian, and I have been working in the field for a number of years, I don't want to say how long, but a number of years, and I've seen many, many clients living with inflammatory bowel disease. And I hear from many patients that when they do eat foods, they do feel it plays a role in their disease. And so what I hear from patients most commonly is that when they eat too much fat, for example, they may have more symptoms. Eating raw fruits and vegetables. A lot of patients have received dietary guidance to follow a low residue diet. And a low residue diet I'll talk about in a moment, but really cuts out all of those fresh fruits, vegetables, fiber, and definitely kind of doesn't go along with some of the guidelines we're hearing when it comes to microbiome research. So I just want to acknowledge that as a working clinician, I do hear that food is important to individuals. And so, as Deanna mentioned, we do have guidelines for dietary guidance, but not strong guidelines. And what's interesting is when I was doing my training, for example, we were taught in our courses that individuals with inflammatory bowel disease should follow this low residue diet. And as I became more interested in science and looking at all the research, I thought it was kind of strange that we were recommending this low residue diet, but when I started looking into the microbiome and became very interested in the microbiome, I realized, what if we were doing some detriments to individuals living with inflammatory bowel disease by telling them to cut out fibers, fruits, and a lot of the vegetables, cutting out dairy and these major food groups, when the evidence was saying if we want showing positive links between some of these foods and the microbiome. And there certainly is evidence today to suggest that we should be increasing our dietary fiber content and amongst these other foods. So these current guidelines, when I did delve into the literature, were based on a very poor study, and it was just one study, which was absolutely shocking to me that our guidelines came from just one study. And I don't think that would consist of evidence-based guidelines. And so my goal was to look at, well, figure out like what we could be recommending for individuals with inflammatory bowel disease. And I just want to highlight that certainly a low residue diet can be useful for a very short period of time, but unfortunately what I find in practice is that a lot of people have been following this diet for a number of years. So that brought me to my PhD thesis, and truly the reason I decided to do a PhD is because it really was frustrating as a dietitian to see many clients and patients and hear that in fact, have them come see me and for me to say, well, I really don't have guidelines, but you can try this. So I set out to meet, I guess, I met with Deanna. We had some of the same goals. So my goal really coming to the Okanagan was to look at this, how maybe a Mediterranean diet may actually help individuals with colitis in particular. And so what we did was we provided a Mediterranean diet intervention to one group, and to the other group, we just had them follow their regular diet. So a lot of them were just consuming Canada's food guide. And so not to get too bogged down in the details, but of course we wanted to look at one marker of inflammation. It's a fecal calprotectin, which is a marker of inflammation that is used to examine inflammation in the colon. And it's used more and more in clinical practice. And maybe some of you, your gastroenterologist is using that now as a marker of inflammation. And then we also wanted to look at, is this affecting symptoms? So is it going to reduce maybe the frequency of individuals going to the washroom? Is it going to reduce blood in the stool? So I recruited for the past number of years and was able to see a number of individuals were quite interested in being involved in this study. But because I was looking at ulcerative colitis patients that were more in a remission phase with mild to moderate disease, I ended up with 32 participants, and those participants were randomized into two groups. One received Mediterranean diet, and then one received, they didn't make any changes to their diet. I was happy to see that we had, in the end, we didn't have anybody drop out because their symptoms worsened or their disease flared. It was really just clinical studies can be challenging, and some of them had to leave the study due to family circumstances. So my sample size is 15 in the Mediterranean diet group with 13 in those following their regular diet. And so most of our participants came from British Columbia, but we had some from Alberta and one from the Toronto area. And so what I wanted to do was look at a few different factors, one being disease activity. So with these changes in diet, would there be a change in disease activity? And again, that was looking at symptoms, blood in the stool, frequency. Would it decrease that urgency to go to the washroom? The other thing that I was particularly interested in as a practicing dietitian was, could the people in my study actually comply with the diet? Because if it was too hard to prepare the meals, took too much time, it's not going to work in real life or real life practice. And, can they still eat out with friends? Can they still enjoy social events and things like that that involve food. So that was really important for me to look at the compliance. And then of particular interest as well was, would these diets make changes to the microbiome? And what's interesting is that there was actually no literature, and there still is no literature at this time on how the Mediterranean diet may influence colitis. But there is some good emerging evidence that the Mediterranean diet may be beneficial in Crohn's disease. And so what the Mediterranean diet looked like, or what the intervention looked like, is that I use this little booklet. And if you are interested in following the Mediterranean diet, I actually have had really good feedback around this little booklet, because it's actually quite practical, because it gives you 4 weeks of different little menu plans, just to, not that you have to follow it exactly day by day, but it gives you ideas on what your breakfast, lunch, and dinner could actually look like, and how you could make it more Mediterranean-like. And then it has some recipes, different snacks, that kind of thing. And it's actually available through this Old Ways organization for a very small fee. And they actually have some really good webinars and even more recipes on their website, if that's something you're interested. And what I really wanted to emphasize with the individuals I was working with is that you could enjoy a lot of beautiful foods that taste good, that make you feel good, that were colorful. And it was one of my favorite parts of my PhD, is just taking the time to speak with different clients and provide them with different ideas and recipes for different foods, because at the core of my being actually is consuming a healthful diet and cooking. So what was really exciting is that the individuals that were able to follow the Mediterranean diet, or that I intervened with and provided information and practical tips on how to follow the Mediterranean diet, were able to actually increase their consumption of fruits and vegetables. And even though they actually were in a raw form, sometimes we had to modify them by blending them or maybe cooking them a little bit more. Individuals can, I encourage them to consume more dairy. And a lot of people had concerns about dairy because they had eaten it in the past and it increased symptoms. So we talked about lactose and decreasing lactose in their diet, just so that they could get those good fats in. Another really important component of the Mediterranean diet is going a little bit more plant-based. It's not a vegan or vegetarian diet at all. You can consume meat, but just consuming less meats in the diet, in particular, less red meats. And of course, olive oil, coaching them on how to reduce those omega-6 in their diets, and encouraging them to eating more fish from omega-3. So we did see positive changes in compliance. And this chart just basically looks at the Mediterranean diet baseline in week 12. And the MDSS is just a particular tool that's used to assess compliance when you're looking at the Mediterranean diet. The other thing that was really interesting is that those that changed their diet to be more Mediterranean-like actually in the end had a better quality diet. And so this is through this measure called Healthy Eating Index. And so what's important about this Healthy Eating Index, or the takeaway really, is that there's been many studies showing that if we can improve the quality of our diet, so that means increasing more vegetables and fruit, changing the different types of fats we consume in our diet, increasing fiber intake, that it is associated with better health. And so my little picture on the side, these are called violin plots. And so it kind of gives a picture on how things changed, how the individuals that consume the diet changed over time. So the wider it is, these violin plots suggests that in fact, these individuals had a higher quality diet, and it was statistically significant. And so I also feel we know that diet influences quality of life, and I'm sure if any of you that have IBD, when you are in a flare, quality of life can be very challenging, and it can be very challenging to eat out with friends, enjoy social engagements, because that fear that if you do eat something, you know, you're going to have to go to the washroom, or there's going to be more pain, or it's going to feel like your IBD is getting worse. So we did look at quality of life. And what was really, really interesting is that those that followed the Mediterranean diet actually saw an improvement in their bowel symptoms when we looked at quality of life. And so the other thing that's really important is to think about is this going to help, or is this Mediterranean diet going to influence clinical disease? Is it going to help individuals? So the other thing is that we saw that individuals had reduced blood in their stools, as well as bowel frequency, than those that were following their regular diet and didn't make those changes. So as a clinician scientist, I was very excited to see that because I'm sure as a patient, even going to the washroom a few less times a day would be considered a positive factor. And the other thing that we looked at, as I mentioned in the beginning, was this fecal calprotectin. So just, it's a measure of inflammation in the bowel. And I was also very surprised and happy to see that those that followed the Mediterranean diet, more people that consumed the Mediterranean diet actually had a clinical response. So that means that their fecal calprotectin actually decreased by 50%. Or else the other piece that we saw in the Mediterranean diet is that fecal calprotectin didn't change. And why this is important is because fecal calprotectin has been associated with relapse. And so if fecal calprotectin is changing and increasing, there is an increased risk of relapse. And when people didn't change their diet, we did see the fecal calprotectin increase. And so what was also interesting to see is that these individuals actually were able to meet their fiber recommendations, in particular females. And now the males did not achieve their fiber recommendations, but my argument here is that females, our Canadian guidelines are to eat about 25 grams a day, whereas in men, it's about 35 grams a day, which is an awful lot, especially when the literature suggests that most patients with not only IBD, but our general population is only consuming around 10 grams of fiber a day. So it's a pretty lofty goal. And over time, maybe these individuals, their body would adjust to these fiber recommendations, but it has to be a slow process. So why that's important is because the bacteria that are living in our gut absolutely love fiber. We've seen that in the science. They love olive oil. And so the positive piece here is that we saw increased production of something called butyrate. And so we know that butyrate is the important substance produced by the bacteria that actually feed our colon cells and they keep them healthy. These short-chain fatty acids have also been shown to be important in reducing inflammation, protect against things like colorectal cancer, as well as improving the intestinal barrier. So one thing that's really important is that it increases the mucus that's lining our digestive tract. And that mucus is very, very important in protecting our intestinal lining from some of the microbes. And if we don't protect our intestinal epithelial lining, what happens is those microbes want to eat that mucus and as a result of that, are basically having to feed on mucus to stay alive. And that's not something that we want. The other thing, I know this is a little bit complicated, but this is like the results of our microbiome studies. So basically, we took the fecal samples from individuals from the beginning and at the end of the study, and then we do all these I guess, tests behind the scene and come up with the bacteria that are most associated with the Mediterranean diet. And what's important here, and I'll just do a high-level summary, is that some of these bacteria are associated with particular foods in our diet. So this first one here, this Flavinofracter plauti, is, for example, associated with consumption of catechins, and catechins are like a prebiotic, and they actually feed the gut microbes, and they're found in foods like grapes, apricots, red wine. Another type of bacteria, the Lactococcus lactis, is associated with fermented foods. So those individuals that ate more fermented foods, for example, had higher levels of that Lactococcus lactis. So what's interesting is that a lot of the components or these bacteria that increased in these individuals' diets would be high in the Mediterranean diet. One last thing that I wanted to examine was I wanted to make 100% sure that if individuals with inflammatory bowel disease were to follow this particular diet, in particular colitis patients, would they be able to meet their nutritional needs? And so what we did find is that once they did start following the Mediterranean diet, a lot of their, some of the nutrients that I consider, or the literature considers, of concern for inflammatory bowel disease patients did go up when they were following the Mediterranean diet. And as a result of that's likely due to the higher quality diet that they were consuming. So obviously iron is of a concern if you're losing microscopic amounts of blood in the stool. Calcium is very important for bone health. And our females, for some reason in the Mediterranean diet, had difficulty meeting their calcium needs. Although they did increase, they still weren't able to meet those calcium needs at 100%. So what that actually said to me was that that we should actually pay attention to calcium needs in the inflammatory bowel disease population, because it's still, even though we're following a Mediterranean diet, we need to make sure that those calcium needs are met to prevent osteoporosis. And what was interesting, we also saw vitamin E and choline. We just weren't able to meet their needs through the diet. And so some simple techniques to, for example, increase choline would be to increase intake of eggs, which of course is allowed on this particular diet. And so just want to finish up with some practical recommendations, because I think there's differences when someone's in an active flare versus that in remission. But I don't think our fiber guidelines stand whether you're in active disease or in remission, meaning the low residue diet. I really do think it boils down to the type of fiber. So we really need to emphasize that increase in soluble fiber intake, because we do need the production of butyrate, those short chain fatty acids, to kind of get your gut working again. And we need to fuel those colon cells and produce like a healthy environment in our digestive tract. So a lot of people come to me and say, well, I can't tolerate fruits and vegetables at this time. And so my best recommendation is that there's lovely, beautiful smoothies out there, lots and lots of recipes that if you really blend down those foods, it's an easy way to get in that soluble fiber. Another way is using different types of soups, blending them down. You can hide a lot of vegetables within these different types of soups. And something like as simple as a chia seed pudding, for example, is an easy way to get some soluble fiber, and it actually tastes quite good. Sometimes in active disease, malnutrition is a concern, having challenges gaining weight. And one of the most simple ways to increase calories in your diet without increasing volume would be to add olive oil into the diet. And so what I recommended for the patients I was working with was increasing that olive oil to a tablespoon 3 times per day. And I had a lot of people look at me funny and say, well, how would I get that in at breakfast? And so an easy way to get olive oil in at breakfast is that there are some really nice flavored olive oils that maybe lemon flavored olive oil, orange flavored olive oil that can be put into a smoothie that can give it a very nice taste. Or for example, if you had oatmeal or overnight oats, mixing a little bit of that type of olive oil into your breakfast can actually, it actually tastes quite nice. Things like hemp hearts, chia seeds are another source of soluble fiber. Just some different ideas on how to get some more fiber in. Overnight oatmeal, like I said, chia seed pudding. And the other really interesting component that's coming out in the microbiome research is that increased consumption of some of these emulsifiers in our diet have been associated with increased risk with inflammatory bowel disease and also detrimental changes to the microbiome. So from a diet perspective, what that means is trying to move away from some of those highly processed packaged foods that have lots of these different types of emulsifiers, which are a concern when it comes to the microbiome. You can try reducing lactose. And so some of the foods that are lower in lactose are the hard cheeses. Yogurt tends to be a little bit lower in lactose. And then, of course, increasing protein, because sometimes protein is lost in the gut. So you can do that through different types of nut butters. Greek yogurt is higher in protein and things like that. So, and lastly, just these are the recommendations I would provide at this point in my practice for remission. And for both of this can be beneficial for Crohn's and colitis. Even though I only studied colitis, there is some interesting research now when it comes to the Mediterranean diet and Crohn's disease. So how we eat more Mediterranean-like is, the goal is to try and get a fruit and vegetable in at every single meal. So breakfast, lunch, and supper. Using a really good quality olive oil. And so I'm emphasizing a good quality olive oil, and it may be a little bit more pricey, but going to some of these specialty olive oil stores, because they actually source their olive oil, they know exactly what's in it, and they can give you some guidelines on what's a good quality olive oil. A lot of these stores have tested their olive oil, as well as they'll allow you to taste it. There are differences in taste between olive oil. We also recommend increasing omega-3 from food. So our Deanna and I are in agreement that we probably shouldn't be supplementing with an omega-3 supplement per se. The benefits actually come from the foods themselves. And I've listed the types of fish that actually are higher in the omega-3 fat. Another tip is adding in some nuts. And so if you can't eat nuts whole, then using different types of nut butters. Whole meat meals is important to reduce the consumption of these emulsifiers. Another part is beans, peas, and lentils. And again, I hear from clients, well, I can't eat those foods, but sometimes using a canned source of beans, peas, or legumes, because they've been sitting in that the fluid for a long time. If you actually take say chickpeas, rinse them really, really well, it actually gets rid of a lot of the galacto-oligosaccharides. And it's the galacto-oligosaccharides that often cause the gas and bloating. And the other thing is increasing your tolerance gradually if you have not eaten these foods before. So even starting with a couple tablespoons on a salad at the beginning can make a difference to the fiber content in your diet. And of course, we can't emphasize enough the importance of reducing omega-6 polyunsaturates in our diet. The challenge is our diet is actually quite loaded in these particular fats. And so it's hiding in everywhere. It's hiding everywhere from your salad dressings to mayonnaise, packaged processed snack foods, as well as pastries and pies. And certainly, I think I'm somewhat convinced that this is detrimental not only to the microbiome, but could have potential for increasing inflammation. So with that, I just want to thank you for joining us today, and we're really happy to take questions. And I certainly want to thank Deanna for the opportunity to work with her these past number of years. It's been very exciting to actually come away with something tangible to share with you today, practical recommendations. And when you're doing a PhD, there's so many people involved in your project, and that's the huge list of individuals that have helped me along the way. So yeah, so we're happy to take some questions.
Yes, thank you so much, Ms. Haskey and Dr. Gibson, for that wonderful research on the Mediterranean diet. I know I learned a lot. I found it super interesting. I think we can start off maybe just with our first question here. There was someone in the Q&A posted that many doctors say that food is not part of IBD. How do we find an IBD dietitian for a teen or a young adult, or how could they potentially get in touch with you as well?
Well, I can start this off and then I'll see what Natasha has to say. Lots of doctors, lots of gastroenterologists as well find food frustrating because, everybody is so different, right? It's almost individualized. And so what works for some people may not work for others. I think this attitude, though, has led to a really large delay in not studying diet and doing really good intervention trials in the context of IBD. Of course, everybody has to eat. And so I personally don't think that diet's going to cure anyone's disease. I do think it does play a role in triggering disease. And so there's some thought in my mind that we need to think about prevention in the first place. But if you already have IBD, diet isn't going to cure you, but it can help manage, right? And so you should take the best diet that the evidence suggests helps you manage the disease or helps you manage inflammation. We know that lots of things in the diet stimulate inflammation. And so thinking that food isn't a part of IBD, it's true from the perspective that you can't cure it with diet. And I don't think that it's true, though, that it can help be a part of the treatment because, like I said, everybody has to eat. And so you might as well eat food that is promoting beneficial inflammatory responses and help you manage symptoms. How you find a registered dietitian, I think I'll let Natasha answer this one. It's a really important consideration. And I think you do have to be wary of things that are not evidence-based. So I'll let Natasha answer that.
Yeah, so I agree with Deanna. I mean, even after all the studies I've done, I'm not pretending that medication doesn't play an important role. And certainly a lot of the studies that we have in diet have definitely not taken people off their medications. A lot of times it's even within my study, the people still kept on with their medications. Where we think the role of diet is going to maybe help is maybe in the future, you may be able to maybe reduce the dosage a bit or not escalate the dose. But right now, the mindset is that it would be more of a adjunct of therapy. And so when it comes to diet, as Deanna mentioned, it is very, very complex. And we're learning now that diet will probably in the future be a very personalized approach. And so what works for one person probably might not work for the next person. And it really, what's interesting or cool from my perspective is that it's probably due to the microbes that are present. So if you're eating certain types of fiber and all of a sudden you get symptoms, perhaps you don't have the bacteria to actually break those microbes down, which is why you have symptoms. So I do agree that just sitting down with a dietitian and talking about your diet, maybe, you know, you've tried reducing your lactose and you've tried, you know, changing the dairy products, you just can't get enough calcium in. There's other ways. So yeah, sitting down with a dietitian. And so people can certainly contact me and I can connect you with different dietitians in each province because I do believe that the individual should have somewhat of a specialty in the field. The challenge with dietitians is that we're supposed to know everything. It's not like a gastroenterologist that just works in IBD. A lot of times, like the healthcare system does not have like a specific dietitian that does IBD, but I can connect you with individuals that do have that expertise. The other thing is to ask your team. Sometimes the physician or your gastroenterologist has someone in mind that they're working with and they can refer you to them. And just being aware that you do have access to a dietitian through your healthcare team.
Mm-hmm.
And I just want to highlight, there's a wonderful link in the chat that Crohn's and Colitis Canada has provided. So that can help you find registered dietitians as well. And as Dr. Gibson and Ms. Haskey were saying, it is one of those things that there is no one size fits all. It's kind of like a trial and error process sometimes. So just looking out at what your own sensitivities are and kind of looking to that to kind of gear you towards what might help you or what you might want to stay away from can be very helpful as well.
Exactly.
And even as we suggested here, right? It's you know, the Canadian food guide isn't even in line with what we're suggesting. And so while it is personalized, I think there are general guidelines that are probably wrong and misdirecting people as well. So, yeah.
Yes, exactly. Another question from our Q&A box is, do you happen to know how the Mediterranean diet impacted levels of sulfur compound producing and sulfur sequestering bacteria in the gut microbiome?
I'll let Natasha answer that since her data is hot off the press. And
yeah, so I have not been looking at the sulfur compounds, but one of our colleagues, Dr. Raman from Calgary, that's something that they were very interested in looking at and have found some interesting results in Crohn's disease. So what we know is that protein sources like the red meat, for example, tend to increase those sulfur reducing bacteria. So a Mediterranean diet, you can still eat red meat, but we try and limit it to once a week, kind of not more than that, less if you can. It can be included. It's a great iron-rich source of food. However, it has been associated with some of those compounds that could be associated with sulfur-producing bacteria.
Okay, perfect. And then I think I'll just kind of link these two questions together. They're based on supplement routines. The first one is, can a young adult / teen with IBD take iron? And also with that, would you recommend a probiotic supplement for ulcerative colitis?
Okay, so when it comes to supplementation, again, that's where meeting with your healthcare practitioner, dietitian is important. To give a blanket recommendation on vitamin mineral supplementation, it really can be, I really think it's individualized. And One thing that I'm comfortable with recommending is taking a standard multivitamin, of course. I mean, I don't think any of us eat a perfect diet. I take one myself, but beyond that, I really think meeting with your healthcare professional, getting those iron levels checked, and then that'll tell you whether you actually need an iron supplement. I will mention that females tend to be at higher risk. We're kind of at low normal levels, even if you don't have inflammatory bowel disease. So it's something to keep track of, and it can certainly really, really have an impact on how you feel. You can be very, very tired if your iron levels are low. And I'll let Deanna answer the probiotic question.
Sure. I just want to mention, I think iron is, the thing is that if you have low iron, this is obviously really detrimental. It's very common, especially in kids with IBD. The problem is that on the basic research side, iron seems to be actually detrimental. So iron supplement seems to be detrimental to gut health, both from an inflammatory perspective and a microbiome. But of course, if you have an iron deficiency, you need to supplement or maybe get an infusion. And so again, I think it depends on levels. So it's like weighing risk and benefit, right? Now, in terms of probiotics, this is something that we're particularly interested in my research lab. And I think there's a lot of hope with probiotics, but not with the current ones that we commercially have available. I think in the next decade, we're going to see a lot of new probiotics that are probably going to be regulated more like drugs. And right now, we just have certain probiotics that are on the market, but clearly they're not efficacious. So we do not recommend them because they don't necessarily work clinically, but they have the hope of working. It's just that we may not have the right ones identified yet. So bacteria are really neat because they have lots of different pathways that they can go down and stimulate good things and prevent bad things from happening in the gut. That's really different than taking a medication that has a target, right? IBD is complicated. So just hitting one target, like Remicade, knocking down TNF-alpha, that might not work for everybody. Whereas a nice probiotic, it might stimulate various 10 different pathways. And so the promise of a probiotic is really, really high, but right now we don't have the right probiotics. And most likely if you have IBD, you taking a commercially available probiotic isn't going to do much, and it may not be viable. They're not regulated in stores. If you buy them on the shelf, they're probably not alive. And so it might just be a waste of money at this point.
Okay, that's really good recommendations and information on all of that. A question from Aman, actually. She says, sometimes it can be difficult for patients to eat fiber when they are amidst a flare-up. However, I noticed the Mediterranean diet emphasized incorporating more fiber. Is this specifically in remission or due to an individualized approach?
Oh, I really can't emphasize enough like how strong the literature is when it comes to, if someone asks me, is there something I can do to improve my microbiome? And it really boils down, like it's clear, fiber, it's lacking in our diet, and fiber produces butyrate. So I do acknowledge that some people have difficulties, but one of the nice parts is that just by trying different types of fiber sources, you may find one that you can actually tolerate. And this is for both remission and in a flare. I feel like if we're cutting out fiber for a flare and we're starving those intestinal cells of its primary fuel, it could be making the situation worse. And there's been some actual rodent studies where they have deprived these little rodents of basically starved them of butyrate, and they've developed colitis. So yeah, so we really need to try and just work on not eliminating all the fiber in our diet, but adding it back. And sometimes it just means adding it back slowly. And I think we have a tendency to decide, okay, I'm going to change my diet today, and I'm going to use this rogue example of like, I'm going to have 3 bran muffins because I'm going to increase my fiber, right? And then you wonder why like you're so bloated and feel awful. So I'm not saying that. I'm saying we increase it gradually, and something like a bran fiber is actually insoluble fiber, and that may make somebody feel like the symptoms are worse. So it's more the soluble fibers. So things like beta glucan, which is found in oats. Trying, like I mentioned, a little bit of chickpeas into your diet, and not half a cup, which is kind of the serving, or 3/4 of a cup of the serving size, but even just trying to sprinkle it into your salads, you know, having a few like little changes, get your body used to that. And then maybe the next week, try double that amount and see what happens.
Yeah, I want to point out one thing, is that one message I hear from gastroenterologists all the time is that symptoms don't necessarily equate what's going on inside your guts, right? And so sometimes, you know, when we add in a diet that's making our microbes happy, the microbes are working overtime. And so that can make us feel like we have some symptoms, but they're not necessarily the same symptoms that cause us to, you know, have bleeding in our guts, right? Which is what IBD is, or that inflammation. Sometimes your microorganisms just need to get used to what you're feeding them, and that's so I think the message that Natasha has, like slowly introducing, is really, really important.
And I guess the other thing is that, I know this is going to sound funny, but society says having like gas is very, very bad. And it's actually not. It's actually quite normal to have a little bit of gas. And that means you're actually feeding those microbes. So I just want to emphasize that it's society that's saying that, you know, having gas is terrible, but it is saying that you're actually feeding those microbes.
Okay, this is quite interesting, because I think a lot of the time we think of like fiber as like one collective group, but there's different types of fiber. There's talking about consistency. We're talking about like the effect that they have can be like, there could be multitudinous like effects on the body. You could be talking about the microbiota as well as moving like food throughout the digestive system. So I think that's really important to kind of keep in mind. This is so educational. I love it.
Yeah, and I do want to emphasize that, and it's not just the fiber alone, right? Like that's what, when it comes to the Mediterranean diet, we were able to show that it is the fat too. So it's kind of all these pieces working together versus individual nutrients. So if we put all these colorful foods together, because they have the antioxidants, the polyphenols, which feed our gut bacteria, the fibers, the fat, all of that coming together has all these different effects, which sort of, I personally believe, have the beneficial effect.
Mm-hmm. Mm-hmm.
Because we kind of get caught up on like specific nutrients, talking just about vitamin D, just about calcium, but we don't eat calcium. We don't eat vitamin D. We eat foods.
Yeah, that's a good point to emphasize.
Mhm.
It's all changing the way I'm thinking about it. This is so helpful.
Amazing. I think we're going to wrap up our Q&A period right there. I think that's a great place to stop, and just wanted to thank you ever so much, Dr. Gibson and Ms. Haskey, for joining us today and that fantastic presentation on diet and IBD. I know that's a really important aspect of a student lifestyle, so we really truly appreciate your time today. I hope you have a great rest of your day.
You too. Thank you.
Thank you.
No problem. Okay, so with that being said, we're just going to take a brief pause right here, just as we kind of switch gears to our student panel, about 5 minutes of time in between that last presentation and our student panel. So just sit tight, please, and we will be back in a few moments. I will be sending a link to a Padlet, which will feature both a message board where you can post positive messages to students living with IBD, Crohn's, and colitis, and to also include your questions for the student panel on there. But you can feel free to still use the Q&A box on this Zoom call, because we will be staying on the Zoom as well. And there's also a little word bubble there just for some inspiration as to what to include on the message board. So just bear with us and we will be back very shortly.
And just before we head out, one more last thing to mention is that Ms. Haskey has provided her email address in the chat for anyone who would like to reach out to her regarding nutrition or being connected to a registered dietitian. And welcome back, everyone. I'll just give a couple more seconds for everyone to get back to it. And then we're going to be switching gears for a little bit now. So we wanted to introduce you to a special portion of today's event, our student panel. So our phenomenal panel will be speaking from personal experiences with IBD to answer any questions you might have on navigating post-secondary with Crohn's or colitis. Some of our questions have been submitted ahead of time, but don't worry, we'll still be taking live questions, which you can post on our Padlet wall using the link in the chat. So I'll just make sure that that's in there. Or Isabel, if you wanted to just, perfect. So Isabel's just gonna set that up in the chat. If you have any questions, we're gonna be answering them live as well. We have our wonderful panelists here. And before we get started, we just wanna emphasize that our advice is in no way meant to substitute guidance from any health professionals. As well, each case of IBD is highly variable. And so some of the advice or insight we're providing may be personalized. What works for one person may not always work for another, but that's okay. We're all here to figure out what works for us. So without further ado, I'll hand the mic over to my co-moderator, Isabel, to introduce our panelists.
Perfect. So I did send the links to the Padlet just before our break, so it should be in the chat to everyone to be able to view. I'm just going to give a brief intro to all three of our panelists here with us today, and then we'll get started with kind of just an open discussion between the three of you, as well as answering a few of the questions that have been submitted. So first up, we have Matthew. He's a second-year music student at the University of Toronto. Matthew has lived with Crohn's disease since he was 3 years old and has since been involved extensively with Crohn's and Colitis Canada's efforts to raise funds and awareness. In 2018, he was the National Honorary Chair, and last year he was one of the recipients of the AbbVie IBD Scholarship. Matthew is excited to be part of the Queen's Crohn's and Colitis Committee student panel for this event. Thank you so much, Matthew, for joining us.
My pleasure. Thanks for having me.
And then next up, we have Jalen Watson, who is actually a member of our executive team. She's in her final year of the undergraduate nursing program at Queen's University. Jalen has made a mark on campus by supporting fellow students living with inflammatory bowel disease. Diagnosed with ulcerative colitis at the age of 14, Jalen has openly shared her story about what it's like to live with a chronic health condition. Since her ileostomy surgery in October of 2020, she's gained an even stronger voice for advocating for herself. Jalen is a current executive member of the Queen's Crohn's and Colitis Committee, and Jalen is pursuing a career in nursing to help advocate on behalf of her future patients to ensure they receive the very best care that supports their overall health and wellness. So again, thank you, Jalen, for being here with us today, and we look forward to this conversation. And then our final panelist is my co-moderator, Aman Abdullah. Aman was rushed into an emergency procedure where she was diagnosed with ulcerative colitis just before turning 11. She spent the better half of 2 years in and out of the ICU. Since her diagnosis, she decided to dedicate her life to helping others with IBD and is currently pursuing a career in medicine to one day become a pediatric gastroenterologist. She wants to be able to support her future patients in both their physical and emotional mental health, as well as serve as a live paradigm of hope and remission for other IBD warriors. Aman has spoken openly about her stories in hopes of supporting others like her. And as a past executive member and now co-chair of the Queen's Crohn's and Colitis Committee, Aman founded the university's first IBD-friendly cookbook, has organized a number of awareness initiatives, research fundraisers, and is one of the curators behind today's event. So again, thank you, Aman, for being with us today. And kind of just to open up the floor, wanted to ask if each of you would be willing to share just a few minutes on your IBD journey and how you got to where you are today. So if anyone is willing to start us off, that would be excellent.
I can go first if no one else is. Okay. Yeah, so as mentioned in my introduction, I was diagnosed just before my 3rd birthday. So a lot of the most challenging parts, I guess, I feel like most people's stories are hardest at the beginning when they're being diagnosed, and there's a lot of uncertainty, and like there's not a whole lot of treatment happening because you really kind of need a diagnosis before you really get underway with something really serious like that, I guess. So I feel like most of the pressure was on my parents, who did their best to deal with it. And so, yeah, I was diagnosed with Crohn's when I was about 3. And then I guess since then, I've tried a lot of different medications until settling on Remicade, which I've been doing since I was 7 years old. I'm 18 now, so it's been about 11 years. And I guess the main changes in my life are just really watching my diet, just taking extra good care of myself, I guess, as compared to other people who aren't living with IBD. Medical appointments like missing school or other things for that sort of thing. And then, of course, when bathroom trips become an intrusion in your life, sometimes I've definitely experienced that as well. So yeah, I guess that's in brief my IBD journey.
Thank you so much, Matt.
I could go next. So as was kind of mentioned in my bio, so I was diagnosed with ulcerative colitis just before turning 11. And like Matthew was saying, I think a lot of the frustration with the diagnostic process can be that there's a lot of uncertainty with it. It drones on and you don't really know what's going on. I think because I was at an age where I think I'm a little bit lucky that it happened a little bit earlier in my life, because I had that adjustment period where I was able to kind of like cope with it. But it did become a big part of my life very young, meaning that I missed 2 years of school, going on and off of different treatments, the whole cycle of kind of experiencing a flare-up, trying a new treatment, going on steroids, and then seeing that when the steroids kind of wane off, that you're on a new treatment, things might not work out. So that process took a lot of trial and error, and I think that happened at a big developmental period for me, but I've since been able to kind of adjust to that, and also meet a whole bunch of other people coming to Queen's and just people in university who have also experienced very similar situations. I think that whole experience kind of sparked my interest in medicine, and so kind of turning that experience into a positive was a catalyst for me. I was so incredibly grateful because the doctors and healthcare team supported me as much as they could, emotionally speaking, especially being so young at that time. And I think, like Matthew was also saying, some of the big changes in my life now are mostly to do with medical appointments, bathroom trips occasionally, of course. I'm also on Remicade, and I have been in remission for the past 6 years. And so lots of positive takeaways, and I'll hand the mic over to Jalen now.
Hi, so I'm Jalen. I was diagnosed with ulcerative colitis when I was 14. There's a bit of a trial and error period, like I feel like everyone's journey sort of starts out with. So I was struggling for about 2 years until I was diagnosed. And then I was fairly stable during my teenage years, which I'm really grateful for. I was able, to develop my sense of self and everything like that. And then my second year of university, my medication stopped kind of working. And I kind of went through a whole list of biologics and nothing was really helping. I was hospitalized because I was reliant on IV steroids. So that definitely impacted my university trajectory in my 3rd year. And then I ultimately ended up receiving ileostomy surgery, which was a subtotal colectomy with an temporary ileostomy, if anyone's into medical terms like that. So yeah, and I've been living with that ever since. And I'm currently not on any medication because majority of my colon is no longer in my body, which is pro and a con. So now I do live with an invisible disability. So if anyone has questions about that, I'd be open to talking about that a bit more.
Amazing. Thank you all so much for being so open with your stories. And it's wonderful to hear from all of you. I think kind of just building off of that, would anyone be willing to speak kind of more specifically to the transition from like high school to post-secondary with your respective IBDs? Whether this may be like losing, you're gaining support, friendships, moving out, any worries related to that, or anything that helped in that transition period, really just to gain an understanding.
Yeah, for sure. I think there's positive and negatives to this whole situation. I think this big transition, to say the least. A lot of the positives have to do with kind of finding your own community and sense of support. You go from that sense of community that you built with from your high school hometown and your family, and you're kind of moving away from that. So that's a little bit difficult, to say the least. And it can be a little bit scary because you're not really sure how. I know in my personal experience, I wasn't really sure if I wanted people to know that I was kind of having to go to the bathroom more than often, and kind of those vulnerable points. I wasn't sure how other people might take it. And when I kind of learned that there were other people coming to university who were just like me in that sense, I think that was a big positive experience for me, and finding my own sense of community. As well, I wasn't really sure how that was going to impact my academics. If I experienced a flare up and I was away from school for a little bit, or I just didn't have that kind of energy to be able to focus on things beyond my health, like how was I going to kind of deal with that? And so something that was really helpful for me was being partnered with, so at Queen's specifically, we have accessibility advisors. So basically, these are people who work with us as part of the staff members at this school, and they'll help you with any accommodations you might need in regards to any disabilities that you may have. And so that definitely put my mind at ease a lot.
Yeah, I can definitely touch on that as well. So I'm originally from Vancouver. So it's a big thing when you move provinces, and the healthcare system's a bit different. So definitely I found support early. I got a new GI here. I went to that accommodations office, I think within my first week of school, and, said, what can I get? And kind of had a sort of open conversation with them, and had to revisit that obviously with my surgery as well. But that's definitely a big support. And also dietary wise, moving out, you don't have your parents cooking for you, or you don't have access to your own kitchen. So definitely setting up appointments with, like, I went here at Queen's with the hospitality services, and they're really great about setting up an appointment and talking to me about, what foods might be safe for me, like how they deal with cross-contamination, all that. So yeah, definitely reaching out for supports. And like Iman said, also finding my people here was just really nice. Yeah.
I would say, as demonstrated by Jalen's experiences, it is very important to be proactive, especially when you're dealing with these things more independently as you get older. So for example, so I'm from the Ottawa area, and so I was always, when I was under 18, I was always going to CHEO, the Children's Hospital of Eastern Ontario, for my appointments. And then after that, now I have a GI at the General Hospital in Ottawa. And so I was referred to him by my pediatric GI. And I guess for a while I just sort of didn't think of it much, because my appointments had got to this point where it was only every like half a year basically, because I was mostly in remission during my teenage years. So I think for a while I just sort of didn't think about it, and then realized, well, hey, it's been a few months since my 18th birthday. And I guess I was expecting them to contact me, and then I kind of realized, like, oh, they're not going to call me. I've got to call them and get that figured out. So I did that, and yeah, I think definitely, I've heard other people talk about this too before, where in the adult care world is definitely different from the children's, and adult GIs are even busier maybe than the pediatric GIs, and people don't always have the time to be proactive in taking care of you. And that's not that's not to take away from the amazing job that all those healthcare workers are doing. I think they're all phenomenal and trying their best, but it's definitely a really busy system with a lot of people in it. So it definitely is up to the individual to make sure you're being really proactive and taking care of yourself, and yeah, like seeking out medical appointments and making those yourself, and then other things as well. So not just your regular like checkups perhaps, but other appointments with other different healthcare providers to see if there's other improvements that you can make to your life and to your well-being. So yeah, I guess my point is just it's important to make sure that you're on top of things and you know what kind of medications you're taking. One really helpful thing that I got from I think the receptionist from my new GI's office was this list of contacts. So list of people who I can call or email if I need a question about something. So like all their names, what their role is or their profession is, and their phone number in the email. And I've definitely relied on that a few times to get help when I needed it. So having that sort of thing too is really helpful. So yeah, that's what I would say.
Those are all really amazing tips and tricks. And I didn't even consider, Matthew, how you were saying at 18, because now you're considered a legal adult, having to switch that care team over, and also having to adjust to a new environment that you're living in. So I can't even imagine how like stressful that can be at times. But I think what you mentioned, and all of you had mentioned, that proactivity, making sure that all of your kind of ducks are in a row, in a sense, to help that smooth that transition is definitely awesome. Does anyone else have any additional comments related to this question? Okay. I know, Iman, you briefly touched on kind of your academic studies. I think there was a question from the pre-registration, but then also some pre-written ones related to that. So maybe we can touch on that next. I know that there was one registration question related to dealing with kind of guilt if you have to kind of take a step back from academics, and then just in general, how you would go about like how your academic studies have kind of been impacted by IBD. So kind of balancing between that guilt, but also kind of succeeding as much as you can.
I can start talking about this a little bit. So like I said, I was hospitalized once when I was in second year, and then for a longer period of time during my third year. And since I am in a clinical-based program, being in nursing, it was definitely really difficult. I found myself, I was at one day at clinical, the next day I was a patient a few floors above them. So it's definitely an experience where you kind of what Dr. Tripp talked about, you have to put your own mask on before you can even think about helping anyone else. And I think same thing goes with academics. Speaking for myself, being a very academically driven person, I definitely have had moments where I've wanted to push through, but taking my own like accountability into mind and knowing that I'm not actually putting my best foot forward if I'm doing it in an unhealthy manner and I'm, knocking down my health in the process, it's definitely not worth it. So that was definitely where I worked with accommodations, as well as my instructors were very understanding. And honestly, it depends on your level of transparency. I'm a very transparent person. As I said, I can't see any of your faces. And I just told you guys I have a bag attached to my stomach. Like I really, I'm past that point in my life where I'm like, I was previously insecure about it and now not so much. But also working with accommodations, they've told me I don't have to disclose anything to anyone. Those accommodations are there. And if they have any questions about it, they could take it up with the accommodations office. But I honestly found that being transparent with my instructors, definitely since they're in the nursing field as well, they kind of understood. So far, I've been having great experiences in my 4 years here, just, taking life as it comes, and the accommodations have been great. So that's kind of what I have to say about it.
I have things I can say about this, but I've also noticed that there's a question in the Q&A, and I think it was also copy pasted to the chat, and also there's an attendee with their hand raised. I don't know if it's the same person, but I hate to interrupt this section, but I just figured maybe we should answer people's specific questions now first. I don't know how you want to do it. I know you're in charge as adults.
No, yeah, for sure, Matthew. I know that there was a specific question directed towards Jalen. It says, thank you for sharing your story. And in terms of how does the surgery, having most of your colon taken out, affect your day-to-day life? And I guess you touched on that a little bit, but yeah, if you have any more specifics.
Yeah, definitely. So I do have an ileostomy bag attached to my stomach. So on a daily basis, I would say it's like more or less, it depends on how, I don't know how I want to phrase this. So it depends on how your colitis was affecting you prior, or Crohn's was affecting you prior to surgery. So for example, I was in a really bad flare. I got to the point where like I couldn't sleep. I was waking up every hour and I had to go to the washroom. So it's very inconvenient in my life. Whereas now I wake up once at night to empty my bag, and maybe empty my bag 3 to 5 times during the day. So it really just depends on what your lifestyle can like take and handle. And my surgeons were really great about talking to me about that. And something that kind of helped me normalize it was, it sounds kind of funny, but I would look up like certain influencers, and like there's even some people that are now TikTok famous that have, you know, bags attached to their stomach, and kind of seeing how that would affect my life and how that's affect their life. You know, as I said, I'm no longer on any medication. I had a lot of dietary restrictions prior to my surgery that I no longer have anymore, which has been really great. But yeah, I would say I live a fairly normal 20-year-old lifestyle despite having my bag. So yeah.
Thank you for sharing. I see that Shoshana has her hand up, or their hand up. If you have a question, feel free to use the Q&A. We just can't have anyone like unmute themselves or turn on their mics. So hopefully that feature is working for you. But please, yeah, please share your questions in there and we'll be sure to get to them. And then I guess kind of just diverting back towards if anyone has any more thoughts about academic studies, navigating that with IBD, and if there was any times that you had to kind of remove yourself for an extended period of time, and how you went about overcoming that.
One thing that I could use as an example is in high school, I think it was in grade 11 in the second semester, I always had Spanish class, last class of the day, and I kind of got into this habit of like needing to use the washroom at the end of the day before I got on the bus, and that's one thing actually that I've always had kind of as, I don't know, I wouldn't want to call it an anxiety. I don't know if it's that like serious, but I've always had this paranoia about having to use the bathroom while like on like a bus or public transport, or even just in the car with my family, because I guess this happened before where I've suddenly, you know, get this urge to use the washroom and we're in the middle of the highway, like next exit's like 5 kilometers, and then it's like this panic scene. And so that happened a lot throughout my childhood, and I think my parents would like travel with like this porta potty thing in the trunk of the car just in case I needed to use that, because we couldn't get to like the gas station or the Tim Hortons or whatever. But yeah, and so that kind of carries through with me till today, I guess. And so in high school, I was always so worried, like, oh my gosh, what if I have to use the bathroom while I'm on the school bus? And I think the school bus ride was almost like an hour for me, and so I'd always wanted to use the bathroom before the end of the school day. So my teacher, I kind of had this, I talked to my teachers about it very openly, like Jalen was saying. It's really helpful to be very transparent with people and not just say, you don't have to always say why you need a certain accommodation, but it definitely helps people to understand, because yeah, people just might not know otherwise, right? And so we had this kind of arrangement where I would leave the class 5 minutes early every day to go and use the washroom. And so people would be like standing by the door waiting to get out. And then I would have like this, it'd be kind of a little bit awkward sometimes, and because I felt like the spotlight was on me, because I would be allowed to leave early, whereas everyone else wants to leave but isn't allowed yet because the bell hasn't rung. But I think by that point as well, I went to a very small high school, and I'd probably done some sort of presentation or just talked to a lot of people about having Crohn's. And so it was like the embarrassment or like I feel like saying public humiliation is a bit too far of a stretch, but that sort of feeling was definitely kept to a minimum because of how transparent I was. And so it can definitely be uncomfortable to have those kind of conversations with people or just to tell them about it. But in the long run, I think it is very helpful, and ultimately you're helping everyone else to raising awareness of IBD and doing that sort of thing. But yeah, that's definitely one thing I guess that I had changed during my high school. And now in Toronto, like for university, I live within walking distance, and there's a lot of places along the way that I can use the washroom. And generally speaking, it's fine. And I mean, like on the subway last night, I was coming back from this hangout with some of my friends, and I suddenly had to use the washroom on the subway, and it did kind of make me fearful, and I hadn't actually felt that in a long time. So kind of a coincidence that happened last night before this panel today. But if worse came, and then like the subway was stuck and it wasn't moving because there's some sort of like security issue, and I thought, oh my gosh, like I'm not even going to be able to get off a few stops early. I didn't really care about being late for my plans at that point, if that's what it came to. I just wanted to go use the washroom, but ultimately it was fine, and I got there in time. And when I got to the place we were hanging out at, I was able to use the washroom. But yeah, stuff like that happens sometimes, for me at least. I'm sure everyone else has had at some point like urges like that if it doesn't occur regularly anymore. But yeah, I think it's definitely helpful to talk to people about it and to get it worked out, especially if there's like a certain schedule that your body might follow, as was my case in 11th grade Spanish class. So yeah, that's one example of that.
I think kind of just going on that thread, my kind of like bodily cycle was the same thing, but it was first thing in the morning. So I'd always be late to my first like calculus class of the day in grade 11. And that transparency, like Jalen and Matthew were both saying, just it did really help a lot. I think, of course, everyone has their own extents to how willing they are to be transparent. But one thing that's definitely helped me was being able to talk to my professors and talk to my teachers and just kind of let them know in advance that, okay, like I might need to use the washroom, or this is how it might affect me. And that way, when things happen unexpectedly, maybe on a daily basis, or maybe there's a flare up, whatever it may be, then they can kind of understand what's happening ahead of time. And then it's not as much of a scramble last minute to kind of explain everything. So I definitely think that that transparency and letting your teachers and professors know, especially as you transition into university, is super helpful. So personally, what I do, and this is kind of facilitated through my whole like advisor system that I was kind of talking about earlier at Queen's, was there's like these formal letters that you can kind of just send to your professors, and just let them know of the accommodations you might need in advance. And if there is something that exacerbates, then you can kind of be able to communicate that to them whenever you need it. And they're just aware ahead of time. So that's something that's been really beneficial for me, I think.
Amazing. Yes. Thank you all so much for helping. And as you all mentioned, speaking up for yourself obviously can sometimes be very embarrassing or uncomfortable at times, even though it is necessary to do so, if you feel like you need that extra bit of support. And to kind of tie into what Aman was just mentioning about the advisory and the accommodation letters sent in, Shoshana's question is related to that in terms of what accommodations can you get at university with IBD. I know Jalen and Aman, you both touched on that, that in previous questions. If there's anything else that you can think of in terms of resources you've used on campus or on-campus supports, and then Matthew, if there's anything specific to U of T as well that you'd like to touch on that you've accessed, feel free.
So, so to touch on like specific accommodations, I know kind of similarly to like stuff I did in high school, like just letting my teachers know that I'd be using the bathroom. And something great that I was told once by someone is I kind of had the anxiety that you guys were talking about with leaving a lecture hall. So I'd always pick like a seat on the aisle close to the back so I know I could like go in and out discreetly. But I didn't realize that, you know, most people are focused on the lecture, or, you know, at worst focused on their phones or online shopping or whatever they're doing. They're not paying attention to what you're doing in the lecture, right? So that kind of eased my own anxiety with that. But going back to the whole accommodations, personally, I've utilized individualized testing. So I test in my own separate room where I have unlimited access to a bathroom. I also now with an ostomy have access to a water bottle as well because of my risk of dehydration because of that. I also have additional time as well, just to accommodate for the fact that I would be using the washroom. I know some other universities use like a start-stop clock method. So you hit the clock when you go to the washroom and then hit the clock when you come back, which I thought was really cool. But yeah, those are some of the accommodations that I've heard of. I've also utilized our student wellness services that we have here at Queen's with just for general doctors and nurses appointments. They're usually pretty good. But yeah.
I haven't had the need, thankfully, to have to eat. Like, I've been healthy enough that I haven't had to request for any accommodations, so I'm very lucky in that regard. I do sometimes, though, like plan out certain things strategically, like Jalen was saying with the whole like sitting near the aisle thing. I think I've done similar things in some of my classes, but even just kind of walking around school and getting really familiar with where all the bathrooms are and that sort of thing, so that no matter where I am, if I suddenly need to use the washroom, I can, you know, have a spot that I can pick. Like I know where I am and where the closest bathroom is, and I've always kind of done that with not just like school, but with public places as well, and knowing which public restrooms are easiest to access or which, you know, cafes don't actually have a bathroom. Sometimes you learn by trial and error in the moment, which is not always fun. But yeah, it's kind of good to have a plan, sort of like to plan ahead of time for those kind of things. So it's like making accommodations for yourself almost in a sense. So yeah, I guess that's just sort of a way of thinking that you develop. But yeah, that's all I can say about it.
I think there's also an app that I've heard of that's been like created and I think advertised on like Crohn's and Colitis Canada. But I've seen that it'll locate, it's called the Go Here app. Yes. And so it'll locate the bathrooms that you can use in public spaces or wherever you are. And it can take into account like where you are and find the nearest bathroom. So that's been really helpful as well. Just kind of throwing that out. And I definitely think that something that's been helpful for me is just like Jalen and Matthew were saying, like planning ahead. I think there's a lot of anxieties that can kind of come with what if I need to use a bathroom right away. And also there's the link in the chat for the Go Here app. But what if I need to use the bathroom, or what do I do? Or so I've kind of developed a routine in like my diet, and I think I've been a lot more fortunate to kind of been more stable with that and my IBD lately. So planning ahead, kind of taking into account your routine, your own cycle, and then like locating bathrooms ahead of time can be really helpful as well.
Perfect. So Shauna, I hope that gives you some ideas on how you can navigate those accommodations with your professors, with your classes, with your test taking, and everything related to that. Now kind of switching gears over towards other aspects of university life and post-secondary life, specifically social life, just in terms of how having IBD has impacted your social lives in university in any way, either positive, negative, or no change. And then as well, if like there's any experiences of FOMO, fear of missing out, related to living with Crohn's or colitis.
I could start. I think lately in the context of the pandemic, something that's been really big is, so I'm on an immunosuppressant like medication. And so that just means that, and you guys can probably hear I sound a little bit sick. I am indeed sick. So I think it's just FOMO can be a thing sometimes, missing out on some events just because it may not be the safest thing to do in a global pandemic context. But I think just kind of being very transparent with those that I trust and has given me a lot of freedom and being able to surround myself by the people who I can be sociable with and have them understand kind of what's going on. And then if there is, in case like the need to go to the washroom, like everyone's kind of aware, and I don't feel like vulnerable or nervous or anything. People understand. I think another big thing that coming to university away from high school was I was kind of worried how that might impact my social life in terms of having sleepovers, because I know that for my own specific like internal clock, I usually end up having to go to the washroom in the morning, and that can be a little bit difficult to navigate. So I think just being very open with people and being able to talk about my own experiences and being around people who do understand it, and even if they don't, they're willing to understand and be open-minded, I think has made like a world of difference for me.
Yeah, I definitely agree, Amon. You definitely weed out people that you don't really want to be friends with anyways when you tell them that you have IBD. So that's been my experience, is like just generally putting my trust in people. And, you know, sometimes you can open yourself to getting hurt or some awkward questions, but it's better that and you let them know ahead of time rather than when you're like in a pain crisis or something like that. Definitely like my IBD impacted my social life, you know, with hospitalization during university. I definitely missed out on a lot of things. And I really felt that even during the year that I had a flare. But recently my biggest motto with going out has been worst case scenario, I just leave. Like that's the worst case, right? Like the worst case is that something does happen. I can't find a washroom or something like that. And I just have to walk home, or I have to, you know, take an Uber home. Like that's really the worst case for me. And that's kind of something that's helped me get over my anxiety of going out and socializing. But yeah.
Well, just like Iman is, I'm also on Remicade, so I'm also immunocompromised. And that's definitely significantly changed how I view the pandemic and act during the pandemic. So I'm studying jazz music at U of T, and so that kind of improvisational music is very social. It's a lot of like group context, and so one thing that people love to do is like there's a ton of jam sessions, both organized and informal, all throughout like the campus buildings that are for music, and then just different venues around Toronto as well. And I haven't been to a single public one yet, and most of the bigger ones that are organized by students I haven't been to either, just because of how people act with their wearing of masks and social distancing. And I've just never felt comfortable being in those kinds of environments. So if I use an example, there's a really popular venue down near Dundas Square called the Jazz Bistro. And so they have late night jams every Friday night and Saturday night. And they do it on this upper floor. It's not the largest space. And because it's such a well-known venue, there's always like dozens and dozens of people there. And they just kind of pretend that COVID doesn't exist. Like no one wears a mask. Everyone's, you know, like giving each other hugs and playing right beside each other, even though they're from completely different social groups. Like there's U of T students, there's Humber College students, there's professionals from the Toronto music scene. And I've always felt like that's too many people to mix and mingle with. Like I feel like my social circle would be way too huge in terms of my COVID contacts. And I mean, that has been changing. It's always been different, I guess, as the pandemic evolves as well. But that's one thing that I always feel like I've been missing out on, those fun experiences and improving as a musician, because to me, that's the fastest way to get better, is to play with other people. So missing out on that and just having fun and also making connections, because it's a great like networking experience when you go to those kinds of events. And so sometimes I've just kind of skipped that, and I'll be at home, and then you look at people on social media, it looks like they're having fun, and you're like, oh crap, and you're comparing yourself to them, and it sucks. So I try not to do that. I try to remind myself that there will be plenty of these opportunities aren't going anywhere. There'll be many more events like this in the future. And once things are safer, especially for immunocompromised people such as ourselves, then I think I'll be more comfortable going to those kinds of things. But in those kinds of situations, I think that I've just spent a lot more time hanging out with one friend at a time or smaller friend groups, And I've kind of always done that anyways. That's just sort of my personality type. I like to have a few close friends as opposed to large friend groups. And so it kind of fits that anyways. But yeah, I think it's important to rely on the people that you can rely upon, like your close friends, your family members, especially when it comes to that sort of thing and you feel like you're missing out on other events. So that's how that's kind of impacted my social life. But I'm optimistic, and I know that I've still got 2 more years of my undergraduate degree after this semester is over. So I'm not panicking about it just yet.
Yeah, that's definitely a good outlook to have. Just out of curiosity, Matthew, have there been any like online opportunities for you to kind of network with the jazz community or to play or perform? I know it's not the same, but
Yeah, there have been online opportunities, I suppose. I was definitely, earlier I was talking about being proactive with your health life. I've also tried to been proactive with my social life and musical life. So my first year of my undergraduate degree last year was completely online, and I didn't even live in Toronto. I lived back at home in Brockville,
okay, yeah.
south of Ottawa. And so but I still would, sometimes you see people on Zoom for classes. Sometimes people have their cameras off the whole time. And so I would go, like, I was like an Instagram fiend, and I would be messaging all these different people and listening to their music on Instagram and try to start up conversations with people. And I sort of made a few friends online, or at least acquaintances, before I even got to school, just from doing that sort of thing. So I guess, yeah, another point would be it's important to try to do what you can given any circumstance, because there will be limitations and challenges in different areas, but there's always something you can do. But yeah, online is a helpful alternative at times.
For sure.
You heard it here, folks. Matthew might be TikTok famous. We don't know. We don't know. It could happen.
I think that's a great piece of advice you gave, Matthew. Just always being ready to be flexible, to pivot. No matter like if you're living with a chronic illness or without. I think that's an awesome way to think. I think we'll just maybe wrap it up with one last question related to kind of those who don't know too much about IBD, or who know people who live with it, but maybe don't know the best way to approach it. So in your experience, how can someone not living with IBD best support a friend with IBD? Maybe speaking on what could have been done, especially related to you, Jalen, and your brief experiences that you shared with friends.
Yeah, so I definitely think the biggest thing for me was being there during even my hospitalizations, or if people can relate, with times during flares. You don't always want to be on your phone, constantly bombarded, but always just a good quick check-in text, or making sure that they know that you are there, whether it's to run to the store and get them an electrolyte drink or something like that. Like, just knowing that you have a support system from that specific person is a really big help, is what I found.
Mm-hmm. And I think just kind of drawing on that consistency was a really big thing that stuck out to me. Was like, I noticed that at first when I was hospitalized, there was a lot of people who were quick to say, oh my goodness, are you okay? But while you're still kind of experiencing things, it seems like, okay, that's not like the biggest news anymore, so it must not be happening. And that can be a little bit difficult. So I think just like continuously checking in on your friends and just seeing, like, even if they're okay, just saying like, hey, how's it going? I was thinking about you, or something as simple as that. And I was going to say something else, but it totally slipped my mind. So Matthew, I'll let you go, and then maybe we'll pop back in.
Okay, sure. I hope it comes back to your mind. I've never had any friends that have IBD. I've always been the only one kind of in my life that I know. Like, as far as I know, at my high school, I was the only one. I'm sure I'm not the only student at the University of Toronto, given that it's such a huge student body that has Crohn's or colitis, but I've never encountered anybody that I know has it. But then again, there might be people in my immediate like social group in terms of my classes who do have it, but just because it can be such an invisible thing, I might just not know about it, because I'm sure that a lot of them who I've met more recently don't know that about me yet, because I haven't been talking about it as much, I guess, which maybe I should change, because I do want to continue being an advocate for that sort of thing and bring awareness to IBD. But a great example of someone being a good friend to me when it came to dealing with my IBD is my friend Christina, who I've known since grade 8, I think. And she's a biochemistry student at the University of Ottawa, but we're both from Brockville. And my mom, who's a school teacher, taught her in grade 7, which is kind of funny. So we also have the same piano teacher, so we kind of have these interconnected lives as well. And so I think it was last year or 2 years ago, we were out for a walk downtown Brockville by the river probably, or something like that. And we were just kind of along this path in this park, and I really needed to use the washroom all of a sudden. And I didn't want to bring it up at first, because I thought, oh, maybe it'll pass, or maybe we'll end up getting to a place where there is a washroom anyways. But then I quickly realized I did need to kind of change the route that we were taking to go find a washroom ASAP, because we're off like the main road, so we have to walk back a few minutes. And so I told her, and immediately she didn't seem panicked, but she seemed very concerned, and like she wanted to look out for me and care for me. And so she took me to the place, her old place where she used to work, this fudgery downtown, and she told me to just go in. And even though their washroom isn't public, she just told me to go in there and ask them to use the washroom, and then if they wanted to put up a fuss about it, just say, oh, I'm with Christina, or something like that. And but she was just obviously looking out for me, and she wanted to make sure that I could get that, because I had also spoken to her a lot about having Crohn's, and she had just learned about it through my mom as well through many years. So yeah, she was just really helpful, and she didn't like ask any questions or anything like that. She just helped me find a bathroom as soon as possible, and I think she drove us to get there as well. So yeah, that was really cool of her. And yeah, then like what Jalen said was, it's just like being there for people as well. That's just a great thing to be as a friend for any kind of challenge that someone else is facing. So yeah, those are definitely some ways that you could help someone who is struggling with IBD.
And my thought popped back into my head. So I think another thing is just having like a friend who's non-judgmental. And another thing is sometimes it can be very individualized to the person of what they need. And when they need it, it can change. So even just asking your friend, like, I'm here for you, what you need, just let me know, reach out to me if you like, just extending that offer that you're there for them. And checking in with them and asking what they need can be very beneficial as well.
Thank you so much, everyone. Yeah, I'm on like what you said. I think, yeah, just remembering that even though the telltale signs are no longer visible, that everyone is still struggling with their own symptoms, and whether they're in remission or inactive, I don't know the word I'm looking for, but I think you get my idea, that there's still things going on under the surface. So just always remembering that. I think that goes for people in general. Is there any last tips or tricks or piece of advice that you could give to a university student living with IBD? If you've said all that can pop in your mind today, don't worry about it. But yeah, I'll just open the floor if anyone has any last minute thoughts to add to our conversation. But so far it's been really beneficial, and I hope that the audience has taken something away from this today.
I think one last thing I might say is just kind of owning your story. Like, it doesn't need to define you, but it is kind of part of your life. And so Jalen was saying earlier, like, it helps you kind of weed out the people who are meant to be in your life and those who aren't. And I think just by standing by your own story and saying like, okay, I have certain needs, and what, like, there's nothing more to that. You're still the same person. You're still like just living your life and kind of figuring things out along the way. And so I think just by being comfortable with that can make a world of difference.
I think my last little takeaway would definitely just be the whole thing Dr. Tripp said about the oxygen mask thing. So you need to put your own oxygen mask on before you focus about anything else, whether it be your social life, your academics, anything. Like, your health should be, and with IBD, it definitely really should be your number one priority, because without it, you won't be able to have any of those other aspects of your life. So definitely just seeking help early on, also in your university career, even if you don't think that you need it. It's always great and to have it there in your back pocket. And definitely just looking into, if you're going into post-secondary, whether it be Queens, U of T, anywhere across the country, there's a bunch of accessibility services, which you may not think IBD you need that, but that's where the accommodations come from. So definitely looking into that with whatever post-secondary education you decide to go into.
Yeah, I have, I think, 3 last things I'd like to say, and I know I've done a lot of talking during this meeting, so thank you very much, everyone, for listening to me patiently. I appreciate it. So one of the things was going off of what Jalen was just talking about, and also kind of a question prompt earlier about dealing with guilt when it came to maybe your academics being like hindered by your health. I can definitely think of times this year and last year when I had to, sometimes like I maybe submitted work that wasn't as great as I wanted it to be, or maybe missed a class, or just different things where sometimes I would definitely prioritize my health and always put that as number one. And I did my best to kind of forgive myself for that every time I did, because I reminded myself that in the long run, that's what's more important. And ultimately, if you're not in good health, it's hard to enjoy anything really, including your academic successes. So I think just as a human, like as a creature existing on Earth, like your health is the most important thing you have. And if you don't have that, it's hard to have anything else following it. So it can be hard sometimes to prioritize it, like even just like getting enough sleep and making sure you're eating regularly and exercising. Like for a university student, those are really fundamental things, but it can kind of be pushed under the rug sometimes, but they're very important. And so I think that I'm doing my best to prioritize it, and I can still work on it, but that's one thing that's important, definitely. And it's okay to miss out on other things when you're prioritizing your health. That's definitely okay. So that was one thing. The other thing was Crohn's and Colitis Canada. I think that's Sherry who's operating that computer right now, right? Okay, yes. So as Sherry says, remember AbbVie IBD scholarship applications are now open. As was mentioned a while back, when Isabel was introducing me, I was one of the recipients last year. There's scholarships for $5,000, which paid off like more, I guess the majority of my tuition for this year, which is a huge help. Like $5,000 is an awesome sum of money to be awarded. And I think there were 10 or 20 recipients this year. I can't remember, unfortunately, but there's a lot of other Canadian university and college students being helped out with that. So if you've applied before, and I applied the year before that too, and 15 for the upcoming year. Okay, that's awesome. So 15 possible recipients next year, or I guess this year. I applied the year before. I didn't get in, and then this year I had more people review it. I spent a bit more time writing it, and if I hadn't got it, I would have applied again this year. So don't be discouraged if you apply and you don't get it, because there's only 15 spots out of a lot of Canadian youth with IBD, so there's probably a lot of applications. So persevere and see if you can get one of the scholarships, because they're awesome. And big thank you to AbbVie and Crohn's and Colitis Canada for giving me that. And then the last thing I wanted to say was thank you so much to everyone for listening and coming to the panel, and thank you Isabel, Jalen, and Iman for having me. It's been awesome, and I know I'm not a Queens student, but Queens is pretty close to Brockville, and both my parents went there, so I feel like I have some sort of connection, but it was really cool to be a part of this. Thank you guys so much. And I'm not sure if U of T has this sort of thing, and I might have to look into getting that started up, but I can talk to you about that separately through emails, so not to use people's time on this call for that. But yeah, thank you so much, everyone, to the attendants and the organizers, and also Sherry for, connecting you guys to me. So yeah, thank you so much, everybody.
Yes, thank you so much, Matthew. We've thoroughly enjoyed hearing from your experience, hearing all your stories, and to every panelist here today. Amon and Jalen as well. I can't reiterate that enough. I think with that, Matthew, yes, our email is always open, that we've been communicating with you. So let us know if you need any help with your endeavors on the U of T campus. And I think we'll leave it there for today. That was super amazing to hear from all of you. And just once again, a special thank you to all of our speakers today, a special thank you to our panelists with us right now, and helping us in helping us share our mission to reduce stigma surrounding inflammatory bowel disease. With the registrant list today, we'll be choosing some participants to receive some swag from the Crohn's and Colitis Canada organization. Amon, do you have any closing remarks yourself?
No, I just wanted to thank absolutely everyone for attending today, helping us reduce the stigma, learning about IBD. A huge thank you to Crohn's and Colitis Canada for partnering with us today, with Sherry, who's been doing all of this fantastic behind the scenes that you guys don't technically see because it's behind the scenes, but she's just absolutely crushing it. Thank you to Jalen and Matthew for joining our panel, and to our wonderful speakers today. I won't keep this too long, but I just wanted to say a huge thank you, a blanket thank you to everyone, and we will be choosing those lucky participants to receive some IBD Crohn's and Colitis sponsored swag very soon.